not getting any responses. Okay, good to go. Thank you. So let me just take a minute to remind you where we left off yesterday, and then we'll move forward from there. So we had completed describing the surface anatomy of the heart. We had outlined the heart, indicated where the four corners were, and created the outline. And thus indicating that the heart extends partially to the right of the sternum, between the third and sixth ribs. It's partially behind the sternum, and extends considerably to the left of the sternum from the second costal cartilage down to the fifth intercostal space. Then we drew in some surface landmarks on the heart, the coronary sulcus here, and then continuing over here. Remind you that the coronary sulcus is the atrioventricular sulcus, so that it separates atrium from ventricle. And we put in the interventricular sulcus here, separating one ventricle from the other. And based upon those landmarks, we were able to demonstrate that the right atrium is on the right border of the heart and is immediately to the right of the sternum, extends about a half an inch to the right of the sternum. The right ventricle forms most of the anterior wall of the heart, is partially behind the sternum, and extends a bit to the left of the sternum. The left ventricle forms most of the left border of the heart, extends even further to the left of the sternum. We said that the upper left border of the heart is a little bit of the left atrium. It's actually the auricular appendage of the left atrium. We said that the posterior wall of the heart behind the screen is entirely made up of the left atrium. And we said that the inferior wall that sits on the diaphragm is mostly made up of the left ventricle. And then we used that information. Oh, and I also again want to remind you that we also made a point of the fact that the two outflow vessels, the ascending aorta and the pulmonary trunk, are both leaving from the anterior wall of the heart, that the ascending aorta is on the right side, the pulmonary trunk is on the left side. And I want to stress that point because I don't want you to be confused by the fact that even though the ascending aorta comes from the left ventricle, it actually is on the right side, and similarly, even though the pulmonary trunk comes from the right ventricle, it's actually on the left side. A little later on, we'll see why that is the way it is. It seems like it's backwards, but that's the way it is. And then we used a couple of chest films to reinforce the points that we'd made. We said the right border of the heart shadow is going to be the right atrium. Most of the left border is going to be the left ventricle. The upper left border is the left atrium. And on a lateral chest film, we said that the anterior wall seen here is going to be the right ventricle. The posterior wall will be the left atrium, and the inferior wall, the diaphragmatic wall, is mostly left ventricle. And so it's based upon those spatial relationships that we're able to identify the parts of the heart on a chest film. Okay, so let's move forward from there and now start to talk about how we use the surface anatomy to understand auscultation of the normal heart valve sounds. So on page 217, there's an illustration that indicates the locations on the anterior chest wall of the four auscultation points for the four valves, shown here and here and here and here, labeled for which valve is which. So those are the points at which, if you place your stethoscope at that location, that's where you can best hear the sound generated by the closure of each of those valves. The closure of the tricuspid and mitral valves are what generate the S1 sounds, and the closure of the aortic and pulmonic valves are what generate the S2 sound. So S1, or sometimes referred to as lub, and S2 as dub. So what do we do with this information? Well, certainly you can simply take a shortcut and say, well, I'll just memorize that picture and then I'll know where the auscultation points are as long as I remember the picture. But that's not the best thing for us to do. Rather than memorize this and not understand why the points are where they are, let's take a few minutes to understand why the points are where they are So you don't have to memorize it, so you can always just figure it out. But the other good thing about understanding why they are where they are is you can then use that understanding to figure out where the auscultation points are for abnormal valve sounds. And that's what we're going to do afterwards. In other words, where would you best hear sounds generated from abnormal valves, the sounds being murmurs, where are the locations to best hear valvular murmurs. So if we understand the principles behind auscultation points, we won't have to memorize a whole bunch of unrelated facts. So what are the things we need to know to understand the auscultation points? Firstly, we need to know the surface anatomy of the heart, where the various chambers are, and we've already done that. The second thing we need to know is something that we might notice on this previous slide. When you look at this lateral chest film, you notice that the heart is tilted forward in the chest so that the bottom of the heart is closer to the anterior chest wall than the top of the heart is. And the reason that's important to know is that means that because the bottom of the heart is closer to the anterior chest wall, it means it's going to be closer to your stethoscope, which means you'll be able to hear sounds better from the lower parts of the heart than from the upper parts of the heart. And so we're going to want to use that information. So first we need to know the surface anatomy, then we need to know that the heart is tilted forward, and then the third thing we need to know is a principle that determines where the auscultation points will be. And the principle is the following. You hear the sound generated from a valve best not by placing the stethoscope directly over the valve, but rather by placing the stethoscope over the region downstream from the valve. By downstream, I mean, where does the blood flow to after passing through the valve? You can think of it, this isn't physically correct, but a way to think of it is make believe that the blood is carrying the sound with it, so you have to go to where the blood is going to, and that's where you'll hear the sound. So that's what I mean by downstream. So if we know where the downstream region is from each valve, we know the surface anatomy of the heart, and we remember that the heart tilts forward, we'll know where to place the stethoscope. So let's apply that to these, and you'll see exactly what I'm talking about. Let's start off with the tricuspid valve. And the diagram shows you that the auscultation point for the tricuspid valve is in the left fifth intercostal space right at the sternal border. So why is that the location? Well, the tricuspid valve is between the right atrium and the right ventricle. So the blood is passing through that valve going from right atrium to right ventricle, which means downstream is the right ventricle. So we want to place the stethoscope over the right ventricle. From the surface anatomy we just did, we know that the right ventricle is in the region that I'm outlining here. Part of it is behind the sternum, and part of it extends to the left of the sternum. Well, we're certainly not going to want to put the stethoscope on the sternum, because why would you want to put bone between the heart that's generating the sound and your stethoscope? That wouldn't be very smart. So we don't want to be over the bone, so we want to be over an intercostal space. And so we know that the right ventricle sits behind the left third, fourth, and fifth intercostal space, right? Because this is the region where the right ventricle is. So we have our choice. Do we want to put it over the third, or fourth, or fifth? And this diagram is showing you that you put it over the fifth. Why the fifth? Why not the fourth or the third? And the answer to that is because the heart is tilted forward. And so the bottom of the right ventricle is closer to the chest wall, and therefore closer to your stethoscope. So you want to be over the bottom of the right ventricle, so you go over the left fifth intercostal space. And lastly, we're seeing that it's not just anywhere in the fifth intercostal space, it's right along the edge of the sternum, right at the sternal border. And why do we do it there? Because we know that some place further out here is where the interventricular sulcus is. So as we start moving away from the sternum, we start running the possibility that instead of being over the right ventricle, we're going to be over the left ventricle. So we don't want to do that. So to assure that we stay over the right ventricle, you stay right up against the border of the sternum. So that's the reason that the tricuspid valve auscultation point, the place where you can best hear the S1 generated by the tricuspid valve, is there at the left sternal border of the fifth intercostal space. For the mitral valve, let's apply the same principle. The mitral valve is between the left atrium and the left ventricle. So downstream means left ventricle. That's where the blood is flowing to. So we want to put the stethoscope over the left ventricle. We know the left border of the heart is formed by the left ventricle. All of this is left ventricle. So again, we have a choice. Do we put it over the third or fourth or fifth intercostal space? And again, we choose the lowest one, the fifth intercostal space, which is right where the apex of the heart is, because that's closer to the chest wall. And so the normal auscultation point for the S1 generated by the mitral valve is the left fifth intercostal space, about 3.5 inches from the sternum, or to say it another way, at the midclavicular line. Okay, so how about the aortic valve? Well, the aortic valve is between the left ventricle and the ascending aorta, so the blood is going to the ascending aorta. So that's downstream. So you want to put your stethoscope over the ascending aorta. Remember, we said that the ascending aorta goes up and to the right from the heart. So we want to be above the heart and on the right side, and therefore we go on the right second intercostal space. The right second intercostal space, again, right up against the sternal border. You're over the ascending aorta in that location, and that's where you would hear the S2 generated by the aortic valve. And similarly for the pulmonic valve, which is between the right ventricle and the pulmonary trunk, downstream is the pulmonary trunk. We know the pulmonary trunk goes up and to the left. So now we go to the left side of the sternum in the second intercostal space. You're over the pulmonary trunk. That's where you hear the S2 from the pulmonary valve. Okay, so you see that all I've done is simply apply exactly the same principle in exactly the same way for all four valves, and that leads us to those four auscultation points. So now you don't have to memorize that. Okay, so that's what we need to know for hearing the normal sounds generated by normal valves. Now, what about the abnormal sounds that we call murmurs? Murmurs. So the first question we have to ask is, what is a murmur? What are you hearing when you hear a murmur? And what you're hearing is turbulence, the sound of turbulent blood flow. When blood flows smoothly, smooth flow is called laminar flow. When blood is flowing smoothly, you don't hear anything. It's quiet. But when it's flowing with turbulence, then you hear a sound. And you're all familiar with that when you're listening to the brachial artery to take blood pressure. When the brachial artery is not constricted, you don't hear anything over the brachial artery, but when it's constricted, then you hear the sound of the blood going through the constricted area. Okay? The blood is going through a narrowed opening. So when you hear that kind of sound, a murmur, a sound from turbulent blood flow, when you're hearing it from someplace in or around the heart, you call it a murmur. When you hear it out in the peripheral vasculature, you call it a bruit. It's fundamentally the same thing. Okay, so that's what the sound is that you're hearing. You're hearing the turbulence. So the next question is, with regard to valves, why would the blood flow become turbulent? What makes the blood flow turbulent? And the answer is that if blood is going through a constricted opening, if it's flowing through a constricted opening, it becomes turbulent. If the opening is wide open, if it's of normal size and blood is flowing through it, it's not turbulent. You have smooth blood flow. But when blood goes through a narrowed or constricted opening, then it becomes turbulent, and you hear the sound generated from that turbulence. So then the next question is, why would the opening be narrowed around the valve? And there are really two possible answers to that. One answer might be that when the valve is supposed to open, it doesn't open completely. And the other answer is when the valve is supposed to close, it doesn't close completely. So either way, if when it opens it doesn't open completely, it leaves an opening that's constricted. And if when it closes it doesn't close completely, it leaves an opening that's constricted. And in either case, blood will flow through that opening. In one case, it would flow in the normal direction. In the other case, it would flow backwards or retrograde. But either way, regardless of which direction it's flowing, it's going through a narrowed opening, so it'll cause a murmur. So the next thing we need to know is when are the valves open and when are the valves closed? In what part of the heart cycle is the valve open and when is it closed? So the answer to that depends upon which valve we're talking about. So let's group the valves into the two AV valves, the atrioventricular valves, which is tricuspid on the right and mitral on the left, and the two outflow valves, pulmonic and aortic, pulmonic on the right, aortic on the left. So the AV valves, they are open during diastole, when the ventricle is filling, right? You need the valve open to let blood flow through into the ventricle. So those valves are open during diastole. So what does that mean? That means if when the valve opens, it doesn't open fully, and we call that a stenotic valve, valvular stenosis. So if an AV valve doesn't open fully, you'll get a murmur, and since those valves are open during diastole, you'll hear the murmur during diastole, and therefore we call it a diastolic murmur. On the other hand, if when the tricuspid and mitral valves close, they don't close completely, that's called valvular insufficiency or valvular incompetence, incompetent meaning that it's not doing its job of preventing backflow because it doesn't close completely. And since those valves close during systole, right, they close for the purpose of preventing backflow to the atria, so they close during systole. If they don't close completely, you'll get a murmur, and it will be a systolic murmur. So with regard to the two AV valves, if they're stenotic, you'll get a diastolic murmur. If they're incompetent, you'll get a systolic murmur. And then for the outflow valves, it's just the opposite. For the pulmonic and aortic valves, they are open during systole to allow the ventricles to empty. So if those valves are stenotic, if they don't open completely, you'll have a systolic murmur. And if those valves don't close completely, if they're incompetent or insufficient, then you have a diastolic murmur. Okay? So that tells us when we will hear the murmur. When we will hear the murmur. So the next question is, where do you best hear the murmur? Not where do you hear the murmur, because you'll hear the murmur if you put the stethoscope anywhere on the chest, you'll hear the murmur. But you localize where the murmur is arising from by determining where do you hear it best. And to figure that out, we go back and use exactly the same principles we talked about a few minutes ago. So let's try applying that first to the tricuspid valve. That's the valve we did first when we talked about normal, so we'll do it first now. So if that tricuspid valve is incompetent, right, it's not closing completely when it should close. We know that it should close during systole, so we know it's going to give us a systolic murmur. But if it doesn't close completely, that means that the valve will be allowing backflow, also called regurgitation, from the right ventricle back into the right atrium. So in this case, downstream would be the right atrium. So we'd want to put our stethoscope over the right atrium. We know that the right atrium is on the right side of the sternum, in this region. Again, the heart is still tilted forward. So we go to the bottom of the right atrium, which is the right fifth intercostal space on the right side of the sternum. Remember, the normal tricuspid valve sound was in the left fifth intercostal space of the sternal border. To hear tricuspid regurgitation, since we now want to be over the right atrium, we go to the right side of the sternum. And so that's the location where you would hear a systolic murmur arising from tricuspid insufficiency. If that tricuspid valve was stenotic, That means you would hear the murmur during diastole, because that valve is open during diastole. The blood would be flowing from the right atrium to the right ventricle, so we want to be over the right ventricle, and so that would put us back here where we hear the normal tricuspid valve, left fifth intercostal space. It's not drawn on this diagram, but that's where you would hear a diastolic tricuspid murmur caused by tricuspid stenosis. Okay, let's try it one more time. I'm not going to go through all the valves and all the possible murmurs because it's the same story over and over again. But let's go to the valve that's the most common source of murmurs, which is the aortic valve. So if you have aortic stenosis, since the aortic valve should be open during systole, aortic stenosis will give you a systolic murmur. And since the blood flowing through the aortic valve is going from the left ventricle to the ascending aorta, you would hear that systolic murmur over the ascending aorta, right second intercostal space. So this would be the location where you would best hear a murmur, a systolic murmur caused by aortic stenosis. If that aortic valve was incompetent, resulting in regurgitation during diastole, remember that valve is closed during diastole, so if it's incompetent, you'll get a diastolic murmur, and it would be regurgitation of blood. Blood would be going retrograde from the ascending aorta back into the left ventricle. So remember, to get over the bottom of the left ventricle, we come to the apex of the heart in the left fifth intercostal space. So that's where you would best hear a diastolic murmur caused by aortic insufficiency. Or that would be where you would hear aortic regurgitation best. Okay? And then we can do the same thing for the other valves. I don't want to take the time to go through this, each valve one at a time. It's the same story. You just need to know which direction the blood is flowing in. Is it flowing in the normal direction, or is it flowing in a retrograde direction? And always the case will be, if it's a stenotic murmur, the blood is flowing in the normal direction. And if it's an incompetency or insufficiency murmur or regurgitation, the blood is flowing in a retrograde direction. So that would tell you where you go to be downstream. Okay? All right. So that's the end of the story of auscultation that we're going to cover, and all we're talking about are valvular defects. There are other things that would cause murmurs, but we won't go into that right now. Let's now turn our attention to embryonic development of the heart, and then we'll go from that to talking about congenital defects that arise from abnormalities in that development. So we'll start the story of heart development, as we've started these other stories, at 4 weeks of development, right after the body folding gives us a ventral body wall. And as soon as the ventral body wall is formed, there appears right behind the midline of the ventral body wall a blood vessel that runs right up and down in the chest. And that blood vessel is called the heart tube. But it's really just a blood vessel. And blood is flowing from caudal to cranial through that heart tube. Okay, so this is the blood vessel. It's sitting right behind the midline of the ventral body wall in the embryo, and blood is flowing from here in that direction, upward. Okay, so that's the heart tube. Now, if I tell you that this middle part of the heart tube is the part that's going to become the heart, just accept that for now. Okay, if that's going to become the heart, that automatically tells you that this lower part of the tube has to become veins, right? Because veins carry blood to the heart, and we said the direction of blood flow is that way. So that means the lower part of this tube is going to become veins. We said this part of the tube is going to become the heart, and then that means that the upper part of the tube here is going to become arteries. Okay, so now we can divide up this heart tube and call this veins, call this heart, call that arteries. And now let's take the part that we're calling heart and subdivide that. The lower part that the veins are flowing into, that's going to become atrium. Right? It's being called primitive atrium for right now. You'll see why that's true in a little bit. And then from the atrium, blood flows into the ventricle. And then from the ventricle, it flows out into arteries. So we're saying that this is veins, atrium, ventricle, arteries. And then we give those parts names. Well, atrium and ventricle, that's pretty self-evident. What we were calling veins has a fancy name, sinus venosus, but venosus, veins, right? And the part that we're calling artery, we're going to call truncus arteriosus, but arteriosus tells you it's an artery. Okay, let's just skip bulbus cordis for now. We'll come back to that. Okay, so those are the parts of the heart tube. Now you see on this diagram that the shape of this heart tube, the structure of this heart tube, is changing as we go from this picture to this picture to this picture. It's a little bit complicated to go through what those changes are, and one of the things that makes it complicated is that actually two entirely different things are occurring to make the heart tube look different as you go from here to here to here. So it's a lot easier to understand if we talk about the differences one at a time instead of trying to do it all together. The first thing that's going to be different is that the part of the heart tube that's going to become the chambers, atrium and ventricle, has to get bigger than the part of the heart tube that's going to remain vessels, aorta and veins. So this part that's going to become the chambers has to get bigger. And as you look at this diagram, you see that sure enough, the part that's becoming atrium is getting bigger. The part that's becoming ventricle is getting bigger. And truncus arteriosus, not really. Sinus venosus, not really. And you see that even more so here, but let's save that diagram for later. So then the next question we can ask is, so how did that part of the heart tube, how did those two parts of the heart tube get bigger? If they're going to be bigger, they need more surface, more wall to become a bigger chamber. So how do they get more wall material to become a bigger chamber? And the answer is they accomplish that by incorporating their neighbor into themselves. In other words, this atrium that we're calling the primitive atrium wants to be bigger, says to its neighbor, which is the sinus venosus, hey look, sinus venosus, if I can just make you part of me, I'll be bigger. And that's what happens. The sinus venosus gets incorporated into the atrium, and the two of them together now create a larger structure that's going to be the adult atrium, part of which came from the original primitive atrium, part of which came from the incorporated sinus venosus that sort of got sucked into and made part of the atrium. And the very same thing is going to happen with the ventricle. It looks to its neighbor, and its neighbor is this very bottom part of the truncus arteriosus, which we give the name bulbus cordis. And it says, hey, bulbus cordis, if I can incorporate you into myself, then I'll be bigger. And so the ventricle gets bigger by combining the original primitive ventricle with the bulbus cordis. It all becomes one larger chamber, okay, which will become the adult ventricle. Now, the original primitive atrium and primitive ventricle looks different from the original blood vessels, artery and vein here. And the way they look different, when I say look different, they look different on their interior wall. If you look at the surface on the interior wall of that tube, you'll find that in the region of the primitive atrium and ventricle, that wall has a roughened, ridge-like appearance, trabeculated, it's called. It has ridges of muscle. So the original primitive atrium and primitive ventricle have ridges of muscle on their inner surface. In contrast, the original artery and vein have smooth walls. So that means that when the primitive atrium incorporates the sinus venosus to create a larger chamber, that larger chamber will partly have a rough wall, the part that was the original atrium, and will partly have a smooth wall, the part that's the incorporated sinus venosus. And similarly, when the ventricle gets bigger by incorporating the bulbous quartus, that new larger ventricle will now partially have a rough wall, the original primitive ventricle, and partially have a smooth wall, the original bulbous quartus. So when you're looking inside the adult heart, just by looking at the wall, at the characteristic of the wall, you'll know immediately whether that part of the chamber was the original atrium or ventricle, primitive atrium or ventricle, or was it the incorporated sinus venosus or incorporated bulbous quartus. And so more specifically, if we look at this chart on page 196, what this says to you is that the primitive atrium is what gives you the trabeculated parts of both atria. The primitive ventricle is what gives you the trabeculated parts of both ventricles. The bulbous quartus gives you the smooth part of the ventricles. And the sinus venosus gives you the smooth part of actually only the right atrium. The left atrium is going to be formed a little bit differently, not worth our time to go into. But the basic concept is that the rough-walled or trabeculated parts of the adult chambers come from the original primitive atrium and ventricle. The smooth-walled parts come from the artery or vein that gets incorporated into the ventricle or atrium. Okay? Now, let's come back to our heart tube here. We said that there are two different things that are going on here. So we've already talked about one, which was the enlargement to form the atria and ventricle. The other thing that's happening simultaneously is that the tube is going to start bending on itself. So here you see the tube looks pretty straight. Here it's starting to fold on itself, and now the folding continues like that. So if you follow how I'm tracing this, you see that it's folding into sort of the letter S lying on its side. So just to give you the orientation, you're looking at this from the left lateral side. So this is the anterior side, right? This is the anterior side. This is the posterior side. This is the anterior side, posterior side, anterior side, posterior side. So this, what started off as a straight tube ends up folding on itself to be this S-shaped tube. And what that means is two things. Firstly, notice that before it bent on itself, the atrium is below the ventricle. As a result of that folding, because this comes up, the atrium is now above the ventricle. Okay, and so we should anticipate that in the adult heart, the atrium will be above the ventricle because of that folding. And the other thing that we see that's different is before it folds, we see that the artery leaves from the top of the heart and the vein comes in from the bottom of the heart. And then as a result of that folding, we now see that the artery is leaving from the front of the heart and the veins are coming into the back of the heart. So when we look at the adult heart, we should anticipate that we're going to see atria above ventricles, arteries leaving from the front wall, veins coming in through the back wall. That's what we should anticipate. And sure enough, we look at the adult heart, the atria are above the ventricles, the arteries, both of them, are leaving from the front wall, and the veins, you can see here and here and here, less obvious there, the veins are all coming into the back wall. All of the veins of the heart, both on the entering the right atrium and the left atrium, enter through the back wall of the atria. The arteries that leave the left ventricle and right ventricle are leaving from the front wall of those ventricles. And all of that is because of that folding of the heart tube. Okay? So we've sort of got the basics of the development of the heart, but what we've developed up to this point is a two-chambered heart, a heart that has one atrium and one ventricle. And we need to convert that two-chambered heart into a four-chambered heart. So how are we going to accomplish that? This is going to be the process that's called septation of the heart. Septation of the heart by the creation of two septa, an atrial septum and a ventricular septum. Now, this process of septation takes a while. It goes on for a while. It stretches over a few weeks, actually. Remember, we said the heart tube is formed at 4 weeks. The process of septation starts happening in late 4th week and isn't finished until early 7th week. So it takes a while. Because it's taking such a long time to happen, that means there's lots of opportunities for things to go wrong over the course of that long period of time, and therefore you should anticipate there are going to be a significant number of defects related to the septa, and there are, as we'll see. So let's talk about the septation. Now, there are going to be 2 septa, an atrial septum and a ventricular septum. The process of septation is going on over that long period of time, sort of simultaneously. Atrial and ventricular septum formation is going on at the same time, but atrial septum formation sort of is a little bit ahead of ventricular septal formation. So atrial septal formation starts in the late 4th week and is finished by the middle of the 6th week, and ventricular septal formation starts in the early 5th week and is finished by the early 7th week. So they overlap a considerable amount, but atrial septation is happening a little bit ahead of ventricular septation. So even though it's all kind of happening together, let's talk about them one at a time because it's much easier to understand it that way. So we'll talk about atrial septum formation first. Okay, how do we divide the atrium into 2 atria? Now, the best way to start off if you want to understand atrial septal formation is to start off by looking at the adult atrial septum. In other words, see what it ends up looking like, and then maybe we can figure out how did it get to be like that. So here on page 201, we're looking at the atrial septum. The way we're doing that is we've taken the wall of the right atrium and we've cut it open and folded the wall back. We're standing in front of the right atrium, looking into the right atrium from the front. We're looking at the back wall of the right atrium, and that back wall is the septum. Remember, the left atrium is in the back of the heart, so behind the screen. So this is the wall that's separating the right atrium, which is in front of the screen, from the left atrium, which is behind the screen. So that's the atrial septum. And when we look at the atrial septum in the adult heart from the right atrial side, as we're doing here, we see a very distinctive landmark on the right atrium. And that landmark is seen right here. It's called the fossa ovalis. The fossa ovalis. Oval fossa, oval depression. And the other important landmark that we're going to be using is the upper border of that fossa ovalis, which is called the limbus. Limbus. The upper border of the fossa ovalis is called the limbus, which means edge or lip of the fossa ovalis. So let's just understand, if we can, why we have a fossa ovalis. Why does it look like that? We said fossa means a depression. So why does this look like a depression? And the answer is that that part of the atrial septum that we call the fossa ovalis is actually thinner than the rest of the atrial septum. Okay, this part is thin compared to the rest of it, which is thick. So why is that thinner than that? Well, it's for this reason. We're going to see that the atrial septum is actually formed from 2 septa, mostly. And you probably all kind of remember that when you studied this. There are these 2 septa. They're called septum primum and septum secundum. But to be accurate about this, what I really should say is that most of the atrial septum is formed from 2 septa, but part of the atrial septum is only formed from 1 septum. This part is only formed from 1 septum, the fossa ovalis. And because it's only 1 septum thick instead of being 2 septa thick like the rest of it is, it's thinner. And because it's thinner, it looks like a depression. So that's why the fossa ovalis looks like that. Because it's thinner, because that region is only made from 1 septum. Now, let me just get one other thought out there, because I really want to get this idea out of your minds. A lot of people say, or believe, that the fossa ovalis is what was, in the embryo, the foramen ovale. the oval foramen, the oval hole in the atrial septum, and that's not accurate. This was not the foramen ovale. Where the foramen ovale was is actually right under, if I could stick my arrow into the screen and sort of get under the edge of that limbus, that's where the foramen ovale was. Not all of this, but just at that very upper edge, that's where the foramen ovale was. You'll see what I mean by that as we go along. Okay, so that's what this looks like in the adult. So now we have to see how did it get to look like that. So there are some diagrams on page 200. These two plus these two. And those diagrams are intended to show you atrial septum formation. And they do, but my experience is that if you don't already know how it forms, looking at these diagrams is not going to help you. These diagrams are really useful if you already know how the septum forms, and then you want to look at the diagram to confirm what you already know. So we're going to use them like that. We're first going to use some other method to learn how the atrial septum forms, and then we'll come back to these diagrams to confirm that they are in fact showing you what happens. So to show you in a much more simplified way, rather than use these pictures that are in the book, I'm going to use some different, much simpler cartoon-like diagrams that I drew that aren't in your book, so just stick with me on this. Okay, so let's use this very simplified diagram. This would represent the atrium. This would represent the part of the ventricle that would continue down off the page. Okay, so we can see that this part enlarged to give us the atrium. This part is enlarged to give us the ventricle. Here's the junction between atrium and ventricle that really didn't enlarge much. So that's sort of a canal connecting atrium and ventricle. So that's going to be called the atrioventricular canal. On this diagram, this will be the right side, that'll be the left side. Okay? And what our task is going to be is to build a septum right along here like that, build a septum that divides this atrium into a right atrium and a left atrium. But I want you to realize that there's really no point in dividing the atria into two atria unless we're also going to divide the canal, the atrioventricular canal, into two canals. Because what's the point of having two atria if they both simply flow into the same canal? You've sort of defeated the purpose. So not only do we have to divide the atrium, we have to divide the atrioventricular canal. So let's divide that first, the canal first. And that gets divided by an ingrowth from the walls of this heart tube that grow in the diagram I'm going to show you, that it's growing in from in front of the screen and behind the screen toward the center of the canal. So it ends up forming something that looks like that. Okay, so that grew in from the front and the back of this tube. They met in the middle and they create this septum. And that septum is going to be called the endocardial cushion, the endocardial cushion. And you can see that that endocardial cushion is in fact dividing the canal into two canals. We now have a right canal and a left canal, okay, which is what we said we want. So now that we have done that, now we can go ahead and divide the atrium. And we said that that's going to happen with two septa. The first one is called first, or primum, septum primum. And septum primum is going to form by growing in from the upper wall of the atrium. It's going to grow down from the upper wall right along like that. It's going to get longer and longer. So let's start to draw that. Here it comes. There's that first septum. And we said that that's going to be called septum primum, first septum. Now, that's going to continue getting longer and longer and longer. I've stopped it at this point so we can just talk about it for a moment. So at this point of development, we can see that septum primum is an incomplete septum. We have not completely divided the atria at this point. There's still a great big opening. And that brings us to an important point. In the development of the septum, there must always be a communication between the right and left atria. Throughout all of prenatal life, in fact, there must always be a connection between the right and the left atrium. There must always be a pathway that will allow blood from the right side to get to the left side. That's a requirement. Why is that a requirement? Why is that so important in the embryo and fetus? Because remember, the embryo and fetus is receiving its oxygenated blood from the placenta. And the blood coming from the placenta comes to the embryo through the umbilical vein, and the umbilical vein eventually will drain into the inferior vena cava, which will drain into the right atrium. So that means prenatally, the oxygenated blood is coming into the right atrium, having come from the placenta. If we want that oxygenated blood to supply the tissues of the fetus, it has to leave the heart from the left side of the heart in order to get into the aorta. So what we're saying is the oxygenated blood prenatally comes into the right side, but it has to leave from the left side. And so that means there better be a way for the blood to get from the right side to the left side. And that's why we always have to have a communication throughout all of prenatal life. And at this stage of development, we see that we do have a communication. Now, one other thing before we continue. We want to build this septum in such a way that not only will there always be a communication between the right side and the left side, but we want to build it so that as soon as the baby is born and starts relying upon its lungs instead of the placenta for its source of oxygen, we want to be able to close the communication and separate the atria from one another. And we want to do that immediately at birth. And so that means we have to be able to accomplish that by using whatever structure is already there in place. We can't throw out the prenatal septum and say, just wait a while we build a new septum. We have to use what's there. So that's going to be an important point that we'll have to see how we accomplish that. So at this early stage of development, we have a septum primum. That's a partial septum. It leaves a great big opening communicating between the two atria, and that opening has a name, and it's called the foramen primum, first opening. Also you'll hear called ostium primum, same thing. But notice that the foramen primum is not a hole in septum primum. Foramen primum is a region in the atrium where septum primum has not yet grown to. To say it a different way, the foramen primum is the region between the septum primum and the endocardial cushion, right? So what that means is that as septum primum continues to get longer and longer and longer, as it will, that means foramen primum is going to be getting smaller and smaller and smaller, right? So let's watch that happen. So septum primum is going to get longer. There it gets longer, longer, longer. It's growing toward the endocardial cushion. So now I'm going to stop it again at this point. So now foramen primum is much smaller, but still is a pathway from right to left. But recognize that if septum primum keeps going and reaches the endocardial cushion and fuses with it, that means there won't be a foramen primum. And if nothing else happens, that means we will have completely separated the atria, which means we killed the embryo. So how are we going to avoid killing the embryo? Because in fact, the septum primum will continue to grow and it will fuse with the endocardial cushion, and foramen primum will close as a result of that. So how do we avoid killing the embryo? We do that by having a part of septum primum perforate. This upper part of septum primum is going to perforate, and the way that happens is by a process of apoptosis, programmed cell death. And so up in this region of the septum, it will start to perforate, and those perforations will coalesce. Something like this happens. Those perforations coalesce and thereby create a hole in the septum, and that hole will be given a name, and it's going to be called foramen secundum. foramen secundum. The important point to realize on this is that foramen secundum forms before foramen primum closes. Remember, this is continuing to grow down. So this better open before that closes, because if it doesn't, we will have completely separated the atria and killed the embryo. So this opens before that closes. So now that foramen secundum has formed, now let's allow the septum primum to finish growing down and reach the endocardial cushion. And it turns out that what actually happens is that not only does septum primum grow down toward the endocardial cushion, but the endocardial cushion will grow up toward the septum primum. They grow toward each other. And so let's see how that happens. That grows down, that grows up, and they fuse. And once they fuse, we call that closure of the foramen primum. But that's okay, because foramen secundum is already open, so we still have a pathway to go from right to left. All right? Now, while that has been happening, a second septum started to grow, and that second septum, known as septum secundum, also starts to grow down from the upper wall of the atrium, and it grows down like that. Now, two things to know about septum secundum. First is that it forms on the right side of septum primum, on this side. And the second thing that's important to know is that it is a much thicker septum than septum primum. Septum primum is quite thin, and because it's thin, it's flexible. It can bend. Septum secundum is much thicker, and because it's thicker, it's rigid. It doesn't bend, and that's going to be an important difference. So let's start drawing septum secundum. There it is. It's a thicker line. You see it's on the right side of septum primum. It grows down, actually grows past foramen secundum, keeps going a bit further, and then it stops. That's as far as it goes. That's it. So we've done everything that we need to do. We've now developed the atrial septum. And before we take a look at how it works, let's just see how this relates to what we looked at before as the adult structure. Because if everything that's going to be there is there, this ought to look like the adult. So let's go back and look at that picture of the adult. And we said that when we looked at the adult septum, part of it is thick because it's 2 septa thick, and part of it is thin because it's only 1 septum thick. Well, is that what we see here? Part of it is thick because it's 2 septa. Part of it is thin because it's 1 septum. The part that's thin, we said we're going to call that fossa ovalis. So what we're calling fossa ovalis there is fossa ovalis here. And we said that at the upper border of the fossa ovalis, there'll be a very sharp edge of the fossa ovalis that we're going to call the limbus. Well, sure enough, when we look at this, we see that edge is in fact the free edge of the septum secundum. So the free edge of the septum secundum is what gives us the limbus of the fossa ovalis. Okay, so that's why it looks like that. Now, the obvious question is, coming back to this diagram, is how does this work? Because we said we always have to have an opening to allow communication so blood can get from right to left, and it looks like I covered over the opening. So how is that going to work? And so what we need to do is think a little bit about the hemodynamics, the blood flow in this prenatal heart. Remember, the blood that's coming into the right atrium, where does it come from? Well, all of the systemic venous return from the fetus comes into the right atrium. Right? All of the venous return comes into the right atrium, but also all of the placental return comes into the right atrium. So that means there's a lot of blood coming into the right atrium. On the other hand, coming into the left atrium, the only veins that come into the left atrium are pulmonary veins. So the only place blood can be coming from would be the lungs. And prenatally, very little blood goes to the lungs, and therefore very little blood comes back from the lungs because there's a very high vascular resistance in the lungs because they haven't expanded yet. And so with the high vascular resistance, there's very little blood flow through the pulmonary circuit, therefore very little blood comes to the left atrium. So what we've said is that there's a lot of blood that comes to the right atrium, very little blood that comes to the left atrium, which means that the pressure is going to be higher on the right than it is on the left, which means we're going to have a pressure gradient from right to left. And that pressure gradient is going to be pushing against the septum. Now remember what we said about septum primum. We said that it's thin and it is flexible. Because it's thin and flexible, that pressure gradient that's pushing against it from right to left will cause the septum to bend. In other words, the pressure gradient pushes septum primum away from septum secundum, creating a gap between the two septa, and blood can flow through that gap like that. That pathway that the arrow is passing through, that's what we call foramen ovale. So remember, I made the point that foramen ovale is not the same thing as fossa ovalis. This is fossa ovalis. Foramen ovale is really more sort of a three-dimensional tunnel. One end of the tunnel is at the top of the fossa ovalis. The other end of the tunnel is the foramen secundum. And then the space between the two septa is the tunnel connecting one end to the other. And that's foramen ovale. And that's how the embryo and then the fetus lives throughout all of prenatal life. Okay, so that's the end of the story of how the atrial septum forms. But then one last point. Remember, we said that as soon as the baby is born, we need to close that separation using what's already in place. So how does that get accomplished? Well, let's think about what's happening after birth. Two important vascular changes occur at the time of birth. One is the umbilical vein closes down, and so there's a tremendous drop-off in flow. Without the umbilical vein, you don't have blood coming from the placenta, and so the flow into the right atrium drops dramatically. The other thing that happens is that with the baby starting to breathe, the lungs expand, the vascular resistance in the pulmonary circuit therefore drops, and therefore blood out to the lungs increases, and blood therefore coming back from the lungs increases, so the blood flow into the left atrium increases dramatically. So what we're saying is after birth, the blood flow to the right side drops, blood flow to the left side rises, and that change is sufficient so that the pressure will now be higher on the left than it is on the right. So again, there'll be a pressure gradient, but now the pressure gradient will be left to right. So that pressure gradient will again push the flexible septum primum, but it'll push it from left to right, which means that the septum primum will push up against the septum secundum. And remember, we said septum secundum is rigid. And so it won't bend, so septum primum gets pushed against septum secundum. So there won't be any space between the two septa. And so that means that even though foramen secundum is still there, and the fossa ovalis is still there, blood can't get from there to there because those two septa are pressed together. And that's called closure of the foramen ovale. The pressing together of septum primum up against septum secundum, and that's caused by the reversal of the pressure gradient. I didn't say that the two septa fuse together, I just said that they get pressed together. And they don't fuse together at the time of birth. But in most people, eventually over time, they fuse. But in many people, they don't fuse. In many people, they partially fuse. The important point is it doesn't matter whether they fuse or not, because what's preventing the blood flow is the left to right pressure gradient. As long as the two septa are pressed together, it doesn't matter whether they're fused. It's simply the left to right pressure gradient which occurs at the time of birth. That causes the closure of the foramen ovale. Okay, so that's the normal formation of the atrial septum. So what we should do at this point is take a break, I think, for 10 minutes. And then when we come back, we'll talk about some of the things that go wrong in atrial septum formation and what the clinical implications of those are, so we can understand how you would recognize these defects. And then once we've done that, then we'll go on and talk about ventricular septal formation, and then again, what are the things that go wrong. So let's take 10 minutes, and I'll see you at the end of the break. Okay, everybody back, ready to go. Let me just take another opportunity to remind you that there is a handout for you to pick up in the file share pod that's in the lobby. You don't need it for tonight. You will need it for tomorrow night. So sometime between now and then, be sure that you download that and print it out. We'll be using it tomorrow when we talk about the development of the GI tract. Okay, so we've developed the atrial septum, and now let's start to talk about some of the things that go wrong in the development of the atrial septum. Oh, before I forgot that I promised we would go back and look at this diagram in the book to see if it all makes sense now. So let's quickly go over it. Here we see that there's a septum primum. There's that endocardial cushion dividing the canal into two canals. We see that septum primum initially does not reach the endocardial cushion, leaving a space that we call foramen primum, and that allows blood to flow from right to left, following the pressure gradient. A little later in development, we see that septum primum has reached the endocardial cushion and fused, so there isn't a foramen primum anymore. But by that time, a foramen secundum has opened. There's foramen secundum, so blood is now flowing right to left through foramen secundum. We see that the septum secundum has started to grow down on the right side of septum primum. And then on the next diagram, we see that it has grown even further down, so it's now overlapping the foramen secundum. But we see that the pressure gradient from right to left is pushing septum primum away from septum secundum, leaving a space between the two septa. Blood flows through that space. That's what we call the foramen ovale. And then after birth, we see that the pressure gradient has reversed. So now the pressure gradient is from left to right. That's now pushing the septum primum up against septum secundum, pushing one against the other, thereby obliterating the foramen ovale. Blood cannot get from here to there because the two septa are pressed together. So that's what normally happens. So let's talk about how atrial septal defects can occur. And one kind of defect arises in the following way. Remember, we said that normally septum primum is supposed to grow down and meet and fuse with the endocardial cushion. Well, what if it doesn't? What if it doesn't? What if they don't meet and they don't fuse? That means we're going to be left with an opening that we were calling the foramen primum. Remember that prenatally, blood is flowing through that foramen primum from right to left, and that's normal. But if that foramen is left there, postnatally, since there's nothing here to cover that over, once the pressure gradient reverses postnatally, blood will flow through that from left to right. And that is going to be called a primum type atrial septal defect, primum type ASD. It's a failure of septum primum and the endocardial cushion to fuse, leaving an opening that we call primum type ASD. And postnatally, that leads to a left to right shunting of blood. Now, when blood postnatally shunts from left to right, that means you're shunting oxygenated blood into the pulmonary circuit. That does not cause cyanosis. That does not cause cyanosis. Left to right shunts are not cyanotic. Cyanosis is caused when you have a right to left shunt. When you get deoxygenated blood going into the systemic circulation, that would be cyanotic. But a left to right shunt is not cyanotic. So this type of a defect, this primum type ASD, is called a non-cyanotic or an acyanotic defect. Now, the fact that it's not cyanotic doesn't mean that it's benign. This is not something that you would choose to have. It's just that it's not cyanotic. What happens is you're taking oxygenated blood, sending it back into the pulmonary circuit. In other words, you're overloading the pulmonary circuit. And that overload of blood in the pulmonary circuit can over time lead to vascular changes in the pulmonary vasculature, leading to pulmonary hypertension. So a left to right shunt can cause pulmonary hypertension. But recognize that if that pulmonary pressure gets high enough so that it's higher than the left side pressure, if the pulmonary pressure gets higher than the systemic pressure, then your pressure gradient will become right to left, and your shunt will go right to left. And so what had been an acyanotic defect will convert into a cyanotic defect. And that's what's called Eisenmenger complex. That's Eisenmenger complex, which is the development of late cyanosis. It results from a septal defect that initially is not cyanotic because it's a left to right defect, but then as a result of extreme pulmonary hypertension, it reverses into a right to left or cyanotic defect. Now, that may never happen. If it's a small defect and it doesn't cause very much pulmonary change, then that won't happen. It can happen within weeks or months of birth, or it could happen after years or decades, or not at all. It all depends upon the magnitude of the shunt. Okay, so that's what happens in primum type defect. Now, let me point something out to you. We said that the foramen primum, the way it normally closes, is that the septum primum grows down and the endocardial cushion grows up toward the septum primum. They grow toward each other. That's what normally happens. We now are pretty confident in saying that when primum type defect occurs, it's not because septum primum didn't grow down toward the endocardial cushion, but rather it's because the endocardial cushion did not grow up toward the septum primum. So it's really a defect of the endocardial cushion. And that leads us to give some thought to why there's a defect of the endocardial cushion. Where did the endocardial cushion come from, basically? And we said that it developed as an ingrowth from the wall of the heart tube. But now we need to make mention of the fact that those cells that do that were not originally part of the heart tube wall. They actually migrated to the heart tube, and then they grew inward to become the endocardial cushion. And those cells that migrated to the heart tube are neural crest cells. Remember yesterday we said that neural crest migrates a lot, goes to many different places in the body to become many different things. And because it does so much migrating, we can expect that there would be a lot of defects associated with that migration called neural crest migration defects. Yesterday we talked about one such defect when we talked about Hirschsprung's disease. And so now we're talking about another neural crest migration defect, which is an endocardial cushion defect leading to insufficient volume of endocardial cushion so that it's unable to grow up toward the septum primum, and therefore we're left with a foramen primum. Okay, so that's a neural crest migration defect. And as I said before, when you have one neural crest migration defect, you should anticipate others. So a primum type ASD will have statistical correlation with other neural crest migration defects. Okay, so that's one thing that we know about this. The other thing I would point out to you is notice that because the endocardial cushion is sitting right here between the right and left AV canals, recognize that what occupies the AV canals are the valves. And so it wouldn't be surprising to learn that the neural crest of the endocardial cushion also contributes to those valves. And therefore, it's not a surprise to learn that primum type ASD correlates with valvular defects. And that's true. There's a statistical correlation that when there's a child who has a primum type ASD, they're at much significantly higher risk of also having valvular defects because of the common feature of inadequate neural crest contributing to that endocardial cushion. Okay, so that's the story of primum type ASD. So let's fix that defect and talk about the other major atrial septal defect. Remember we said that the foramen secundum forms by a process of apoptosis, resorption of part of the septum primum perforating it, leading to that opening. Well, what if there's an excessive amount of apoptosis? Too much of septum primum is resorbed, so instead of ending up with a foramen secundum that's that size, how about if we ended up with one that was that size? Much larger. Too much apoptosis. Well, now that foramen secundum is so large that septum secundum is not overlapping, it's not covering it over. So that means that after birth, when we have a reversal of the pressure gradient, remember we said normally the reversal of the pressure gradient would cause septum primum to push back toward the right because it would normally overlap septum secundum. It would push up against septum secundum and thereby close foramen ovale. Well, if you don't have that overlap, that can't happen. Septum primum can't push up against septum secundum. Therefore, you can't get closure of the foramen ovale. You're left with an opening here, and that opening is called a secundum type ASD. A secundum type ASD. Okay? Which is in essence a persistence of foramen ovale because of an inability to close the foramen ovale because septum secundum doesn't overlap foramen secundum. So it's called a secundum type ASD. Postnatally, that will still lead to a left to right shunt. So that's still going to be an acyanotic defect. That's still an acyanotic defect. Now, secundum type ASD is the much more common of the two atrial septal defect types. Secundum is about 8 times more common than primum type ASD. The other thing I want you to realize is that the formation of this defect, which was caused by excessive apoptosis of the septum primum, had absolutely nothing to do with the endocardial cushion and has therefore nothing to do with neural crest or neural crest migration. So secundum type ASD is not a neural crest migration defect, and therefore it does not have association with other neural crest migration defects because it's not a neural crest defect. And also because it's not related to the endocardial cushion, secundum type ASD does not correlate with valvular defects. They're completely unrelated. Okay? So that's secundum type ASD. Okay, last point I'll make, just use this picture on 201 to make this point. If you were to be on the exam, if you were to see an autopsy photograph of an atrial septum that had a hole in it, okay, so you're going to look at this atrial septum, you see that there's a septal defect in it. And if the question were to ask you what kind of septal defect is it, or a more creative question would be what was the developmental mechanism that led to this defect? The question is, can you tell by looking at the septal defect which kind it is? Is it primum type or secundum type? And the answer is yes, you can. And the way you can is by taking note of the location of the septal defect. Remember, a secundum type defect is located where foramen ovale is, because it's a failure of foramen ovale to close. And so a secundum type defect, remember foramen ovale is in the upper, right at the upper border of fossa ovalis, so you'd expect a secundum type defect to be in that region of the septum, right near the upper border of the fossa ovalis. Whereas a primum type defect is going to occur next to where the endocardial cushion was, and remember, that's next to where the valve is. So you'd expect a primum type ASD to be somewhere in this region near the valve. Okay, so secundum type defect would be found here, and that's caused by excessive apoptosis of the septum primum. And primum type defect is found there, and that's caused by a neural crest migration defect leading to inadequacy of the endocardial cushion. Okay, so that's the story of atrial tension to ventricular septum formation. Okay, so again, we'll start off with a very simplified cartoon diagram of how this happens, and then we'll look at some pictures from the book. So on this cartoon, this would represent the ventricle, and this is the outflow from the ventricle, which remember was called the truncus arteriosus. So that's the ventricle, that's the truncus arteriosus. And so again, we're going to want to separate the ventricle into a right and a left ventricle by having a septum. But just as we spoke about before, there's no point in dividing the ventricle into two unless we divide the outflow into two. And so we also need to divide the truncus arteriosus into two outflows so that each ventricle can flow into its own outflow. So we're going to need a septum here to accomplish that. Okay, so again, we're going to have two septa. But this time, instead of the septa being side by side, as they were in the atrium, they're going to be end to end. Now, the first septum, we're not going to spend any time talking about how it forms. It's not important how it forms, just important to know that it does form. And this is a septum that forms within the ventricle, and it's called the embryonic interventricular septum. Two important points to be made about it, and then that's all we'll say about it. First point is, you can see it's an incomplete septum. It doesn't completely divide the ventricle, it partially divides the ventricle. The second important point is that this embryonic ventricular septum forms from the ventricular wall itself. From the ventricular wall itself. And that being the case, that means that the embryonic ventricular septum is made of the same material that the wall is made from, meaning it's made from cardiac muscle. So this is going to be made from cardiac muscle, just like the ventricular wall is made of cardiac muscle. Okay? So that's all we'll say about the embryonic ventricular septum for right now. Let's turn our attention to dividing the truncus into two vessels, and we're going to divide the truncus into two vessels by building a septum right down the center of the truncus, right down the center of the truncus, so that it divides the truncus exactly in half, like that. Once we have divided the truncus into two, we now have two vessels. We give them each a name. On one side it's called the ascending aorta, and on the other side it's called the pulmonary trunk. And so therefore the name that we give to the septum that creates the aorta and the pulmonary trunk is called the aorticopulmonary septum. Aorticopulmonary septum. Now, where does that septum come from? Well, it arises in a manner kind of similar to how the endocardial cushion grows. It arises by ingrowths from the wall of this part of the heart tube. Cells that are at the wall of the heart tube grow inward and meet to form that septum. But also, similar to the endocardial cushion, the cells that do that were not originally part of the heart tube wall. They migrated to the heart tube to do this. And so the aorticopulmonary septum, again, is a neural crest-derived structure. Neural crest cells that migrated to the heart tube and then invaginated to become the aorticopulmonary septum. So when we start talking about defects, we're going to have to realize that defects of the aorticopulmonary septum are also going to be neural crest migration defects. Okay, we'll come to that shortly. So this aorticopulmonary septum doesn't just suddenly end when we get to this part here. It keeps on going. And so it's not only going to divide the truncus, it also keeps on going and completes the division of the ventricle. And because the aorticopulmonary septum is right in the midline, and the embryonic ventricular septum is right in the midline, they meet end to end and they fuse. And so now we've completed the division of the ventricle into a right and left ventricle. We've completed the ventricular septum, but we see that there are two parts to it. One part that came from the embryonic ventricular septum and one part that came from the aorticopulmonary septum. We said that this part, the embryonic ventricular septum, is made of cardiac muscle. The aorticopulmonary septum is not. It has no muscle in it. So when you look at the adult ventricular septum, you'll recognize that there are two parts to the adult ventricular septum, a part that's called the muscular septum and a part that's called the membranous septum. And so now we see that the muscular septum is derived from the embryonic ventricular septum, and the membranous septum is derived from the aorticopulmonary septum. Okay, so now we have the adult ventricular septum completely formed, and the aorta and the pulmonary trunk is formed, and we now have a pathway from the left ventricle into the aorta and from the right ventricle into the pulmonary trunk. Now, let me just sort of give you a preview of something we're going to talk about in a little while. This aorticopulmonary septum that I've drawn as a straight line doesn't really form straight like that, okay? I drew it that way because that simplifies the discussion, and there was no reason not to do it. But the reality is it actually forms in the shape of a spiral, a 180-degree spiral. And so oftentimes you'll hear the aorticopulmonary septum called the spiral septum because it forms in the shape of a spiral. But as I said, for the discussion that we're having now, that fact is really not important, so we're going to ignore it. A little bit later we'll come to some other issues in which the fact that it forms in the shape of a spiral does matter, and then we'll have to deal with the drawing that draws it as a spiral. Okay, but for right now we can ignore that. Okay, so we have the normal septum formed, we have the left ventricle going into the aorta, the right ventricle going into the pulmonary trunk, and that's it. That's normal development. So what are the things that go wrong? Well, the things that go wrong in the ventricular septum often have to do, in ventricular septal formation, often have to do with the aorticopulmonary septum, defects of the aorticopulmonary septum. And the most common of those defects is what results in the most common cyanotic heart defect. Most common cyanotic heart defect, not the most common heart defect. The most common heart defect is a ventricular septal defect, which is not cyanotic, just like an atrial septal defect is not cyanotic. Atrial septal defect is the second most common. Ventricular septal defect is the most common. Both of them are not cyanotic. But the most common cyanotic defect, which is about the fourth most common defect, is a defect that's known as tetralogy of Fallot. So let's start off by using that as our model of ventricular septal defects, tetralogy of Fallot. Now, you've probably memorized at some point in your studies, you probably memorized the four components of tetralogy of Fallot. And so, as you recall, those four components are pulmonary stenosis, overriding aorta, ventricular septal defect, and right ventricular hypertrophy. Those are the four components. That's why it's called tetralogy, tetra, four. So pulmonary stenosis, overriding aorta, ventricular septal defect, and right ventricular hypertrophy. So the obvious question to ask is, why should those four defects occur together, and occur together with a high enough frequency to result in the most common cyanotic defect? That seems a little strange. And the answer to the question is that it really isn't four defects. It's really one defect that looks like four defects. One defect that looks like four defects. And the one defect, which is the defect in tetralogy of Fallot, is a defect in the aorticopulmonary septum, or more specifically, in the position of the aorticopulmonary septum. If you recall, I made a big fuss about the fact that normally the aorticopulmonary septum forms right down the middle and thereby divides the truncus exactly in half. So you'll have two equal sized vessels. In tetralogy of Fallot, what happens is it doesn't form right down the middle, but rather it forms displaced toward the pulmonary side. It's called dextropositioning, position to the right. So it forms like that. Instead of being over here, it forms over there. And therefore, it doesn't divide the truncus in half. You end up with a smaller vessel and a larger vessel. The smaller vessel is the pulmonary trunk, and so we call that pulmonary stenosis. The larger vessel, which is the aorta, is so large that it straddles both ventricles, and so it's called overriding aorta because it sits over or overrides both ventricles. So you see that pulmonary stenosis and overriding aorta are not really two defects. It's just the same defect looked at from two different sides. It's the septum's in the wrong place. Then remember that normally we said that the aortical pulmonary septum meets and fuses with the embryonic ventricular septum. Well, that will happen if the septum is in the correct place. All right, since this is in the midline and that's supposed to be in the midline, they can meet and fuse. But if that's in the midline and that's not in the midline, then they don't meet and they don't fuse. And therefore you're left with an opening here. And so what do you call that? A ventricular septal defect. So that's the third component of tetralogy FLO, VSD, again caused by the aortical pulmonary septum being in the wrong place. And then lastly, we said was right ventricular hypertrophy. The right ventricular wall gets thicker, hypertrophies. And the reality is that's not a defect. That's a result of the defect. It's because you have the pulmonary stenosis, and therefore the right ventricle has to work hard to try to push blood through that stenotic pulmonary outflow, that the ventricle hypertrophies. Muscle is supposed to hypertrophy when increased demand is placed on it, and so it does. So it's really a result of the defect, not a part of the defect, but when it was first described, it was seen as accompanying everything else, and Dr. Fallot considered it part of the defect, and so that still sticks today. Okay, so the result of this is that the oxygenated blood from the left ventricle certainly can flow into the aorta. The deoxygenated blood from the right ventricle, some of it will get through that stenotic outflow into the pulmonary trunk. Some of it will, but a whole lot of it will get shunted through the VSD into the overriding aorta and end up going out through the aorta. Because of the stenosis here, pressure here gets higher, therefore you're going to have a right to left pressure gradient, so you'll have right to left flow through that VSD into the overriding aorta. And it's that flow, this blue arrow here, which is deoxygenated blood getting into the aorta and therefore mixing, that's what results in the cyanosis. That flow is the cyanosis. That is indeed a right to left shunt. So as we've said, right to left shunts are cyanotic. Okay, so tetralogy FLO is the most common cyanotic heart defect. Now, interestingly, quite often these babies are not cyanotic when they're born, but rather they become cyanotic a little later on once they have grown a little bit, become a little bit more active, and as they become more active and their demand for oxygen increases because of this defect, they're not able to meet that demand, and so they become cyanotic later on. Okay, so it is a cyanotic defect. It's just often not seen as cyanotic at the time of birth. Okay, so you see a diagram representing tetralogy FLO on page 204. We see the small pulmonary outflow. We see the very large aortic outflow. We see that VSD, and we see the thickening of the right ventricular wall. Okay, so that's one big defect. A second major defect of the aortical pulmonary septum is a defect in which the septum simply doesn't form. It's a failure of the aortical pulmonary septum to form. That clearly means it's a neural crest problem. But remember that the purpose of the aortical pulmonary septum is to convert the truncus arteriosus into a pulmonary trunk and an aorta. So if you don't have it, you're going to be left with a truncus arteriosus. So we call it persistent truncus arteriosus, which means that both chambers, both ventricles, are flowing into a common outflow, like that, and therefore they mix in that truncus arteriosus. Now, if we follow this flow further downstream, eventually that will divide into two circuits, an aortic and a pulmonary circuit. But by the time it divides someplace up here, the blood has already mixed, so the blood that goes into both circuits is mixed blood. And so you do, in fact, have mixed blood in the systemic circulation, so it is indeed a cyanotic defect. So persistent truncus arteriosus is a cyanotic defect. It results from a failure of the aorticopulmonary septum to form. But recognize something. Remember, we said that that aorticopulmonary septum also was responsible for forming the membranous portion of the ventricular septum. And so if you don't form an aorticopulmonary septum, you have an incomplete ventricular septum, which means that whenever there is a persistent truncus arteriosus, there is always a ventricular septal defect that accompanies it. Always. 100% of the time. It has to be. Because after all, it was this septum that completed this septum. Okay, so if you don't have it, you don't have that either. Okay, and so this is another significant neural crest migration defect. And here's a diagram of it on page 205. We see that common outflow, the truncus arteriosus, both chambers are flowing into it. We see the ventricular septal defect, the absence of the membranous septum. And we see, as I said, that further downstream it does divide into two, but it's too late by then because the blood has already mixed. Okay. Now, we finally have to deal with the issue of the actual shape of that aorticopulmonary septum. As I said, it normally forms by ingrowths from the wall of the truncus, but ingrowths that grow in a way such as to form a septum that's spiral, 180-degree spiral in shape. And this diagram is attempting to illustrate how that's happening. It's growing in from the wall, but the part of the wall it grows in from changes as we go out along the length of the truncus. So in other words, down here near the base, it's growing in from the left side and the right side. That's what you see here. Go up a little higher, and it's growing in from the front and the back. That's what we see over here. Go up a little higher, and again, it's from the left and the right, but what was right here is now left here. So it has been gradually changing the position of its ingrowth from here to there, to there, to there, to there, to there, to there, as we run up along the length. And when you put that all together, you end up with a septum that has a 180-degree twist or 180-degree spiral to it. That's why it's called a spiral septum. And it's for that reason that the two vessels that are developed from that, the aorta and the pulmonary trunk, end up looking like that. Okay? They look like they twist around one another. They seem 180-degree twisted, so it now explains what seemed like a strange a bit of anatomy where the vessel that came from the left ventricle is seen on the right, and the one that comes from the right ventricle is seen on the left. It's because of the spiraling of the spiral shape of the septum, which causes those vessels to take a spiral course around one another. So the defect that we need to talk about is what would happen if that aorticopulmonary septum doesn't form in the shape of a spiral, but rather forms as a straight septum. What if it does not spiral? What if it forms straight with growing in from the same part of the wall all the way along the length? Well, that would mean when you look at the adult, instead of one vessel going that way and the other vessel going this way, the vessels would be parallel to one another. And so you would have one vessel that looked like that. That would be the aorta. So instead of it coming back that way, which would bring it to the left ventricle, comes straight back, so it comes to the right ventricle. And the aorta comes straight back. I'm sorry, the pulmonary trunk would come straight back to the left ventricle like that. Okay, so you have the aorta going out of the right ventricle. You have the pulmonary trunk coming out of the left ventricle like that. and that's called transposition of the great arteries. Transposition of the great arteries. Now, if you think about what the implications of that are, recognize what's happening here in the postnatally. Firstly, before we talk about postnatally, realize prenatally, this is not a problem for the fetus. Because remember, the oxygenated blood from the placenta comes into the right side of the heart. And so if that blood ends up leaving the right side of the heart to get into the aorta, that's fine. That's not a problem. And what's happening on this side doesn't matter because the lungs aren't functioning anyway. But when the baby is born, and now the placenta is not providing oxygenated blood, that means the blood that's in the right side is the systemic venous return. So it's coming back from the systemic return into the right atrium, goes to the right ventricle, then it goes out the aorta right back into the systemic circulation, and then ends up coming back into the right atrium. And so we have a completely closed circuit of deoxygenated blood circulating through the systemic circulation. And similarly, on the left side, you have oxygenated blood coming back from the lungs to the left atrium, to the left ventricle, out the pulmonary trunk, out back to the lungs, and then back to the left atrium. And so we have another completely closed circuit of oxygenated blood. So with those two parallel closed circuits, we have no opportunity for a mixing between them, and therefore you would expect that as soon as this baby is born, the baby should die. But usually that doesn't happen. Usually these babies are born alive and stay alive and are very cyanotic, extremely cyanotic. In fact, transposition of the great arteries, remember I said that although tetralogy is the most common cyanotic defect, but it doesn't present as cyanosis at birth usually, transposition does always present as cyanotic at birth. So the most common cause of cyanosis at the time of birth is transposition of the great arteries. But that leaves us with the question of, why aren't they dead? Why are they just cyanotic? They should be dead if our understanding of the circulation is correct. And the answer to that is because they have other defects that allow connections between the right and left circulation. So they're called mixing defects, like septal defects, atrial septal defects, ventricular septal defects. Usually they have patent ductus arteriosus. Okay, and it's because of these mixing defects that they are in fact alive. Okay, we'll come back and talk about that again later. Okay, so that's what transposition of the great arteries is, and we can see that diagrammed on page 205, from the right ventricle going into the aorta, from the left ventricle going into the pulmonary trunk, and what's being shown here is the coexistence of a VSD and an ASD, because these kids usually have such defects, and that's why they're alive. ASDs, VSDs, and PTAs. Okay, so now let's turn our attention to prenatal circulation and how it's different from postnatal circulation, and what the changes are that occur at birth. So, sort of a good starting point to understanding prenatal circulation is to start off by remembering that the placenta is serving as the source of oxygen. Like the lungs serve postnatally, the placenta is serving prenatally. So that means, just as in the adult, you have fully oxygenated blood coming back from the lungs through pulmonary veins. That means prenatally, you're going to have fully oxygenated blood coming back from the placenta through the umbilical veins. Okay? Which means the blood going to the placenta in the umbilical arteries will not be fully oxygenated, just like the blood going out the pulmonary arteries is not. Okay? So that's sort of the correlation. The placenta takes the place of the lungs. So that's a good place for us to start. Let's start off with the blood flow to and then from the placenta. So the blood going out the umbilical arteries is not fully saturated. Now, in the diagram that's in the book, there are numbers, percent saturation numbers all over this diagram. I'd suggest you just ignore the numbers. You don't need to know the numbers. What you do need to know is relative saturation. Is it fully saturated? Is it unsaturated? Is it partially saturated? That's really what you want to know. And so I will do that by just using the color coding. So red means fully saturated, blue means unsaturated, and purple means something in between, partially saturated. So the blood that's going out the umbilical arteries is, as it turns out, partially saturated. It's not venous blood, so it's not unsaturated. And you'll see why it's partially saturated when we finish this discussion. Okay, so that's what goes out the umbilical arteries, goes out to the placenta, and then it gives up its CO2, picks up oxygen, and comes back through the umbilical vein as fully saturated blood. That's why it's red. That fully saturated blood goes up the umbilical vein, and then the umbilical vein leads it into this other little vein that we're not going to spend any time on, which is called the ductus venosus. It's a continuation of the umbilical vein that allows the blood to bypass the liver. The important point is that that will then lead it into the inferior vena cava. So that's how it's going to get to the heart. But remember that in the inferior vena cava already, coming back from the fetus's lower limbs and pelvis, is the systemic return, venous return. So I'll show that as blue. That's deoxygenated blood. So what we have is fully oxygenated blood in the umbilical vein, which will join the deoxygenated blood in the IVC. When they come together in the proximal IVC before we get to the atrium, they mix, and there's something in between. Something in between fully oxygenated and fully deoxygenated. Okay? Something in between, and that's what enters the IVC to get into the right atrium. At the same time, coming in through the superior vena cava, from the head and neck and upper limbs, is systemic venous return, which is deoxygenated. So that's in blue. So here's an important point for you to recognize, that prenatally, the blood that comes in through the IVC and the blood that comes in through the SVC is different, with the IVC blood being much more saturated than the SVC blood. Now, one might think that when these two flows of blood come into the right atrium, that the atrium would sort of be like a big mixing bowl and the whole thing just mixed together and equilibrates someplace in between. But that's not what happens. There's very little mixing between those two flows of blood. They actually kind of flow past one another and go in different directions. So let's look at them one at a time. Let's start off by looking at what happens to the IVC blood. That's the blood that includes the placental return. It comes in through the IVC, crosses through the right atrium, and goes to the foramen ovale. And that foramen ovale will shunt it over to the left atrium. Right? We've already talked about that. Okay, so the blood gets shunted into the left atrium through the foramen ovale, and from the left atrium it goes into the left ventricle, and then from the left ventricle it comes out through the ascending aorta. Okay, so that's what happens to the IVC blood. The SVC blood comes in through the SVC into the right atrium. It runs through the right atrium, and for the most part, it doesn't go into the foramen ovale. Now, if you just look at how these arrows are oriented, you realize that this blood, in order for it to go through the foramen ovale, would have to make a U-turn. Right? Blood doesn't make U-turns, blood flows straight. So if you follow this blood in sort of a straight line, where does that lead it to? It brings us to the tricuspid valve, which brings the blood into the right ventricle. So the SVC, while the IVC blood crossed the foramen ovale to get to the left atrium, the SVC blood ends up in the right ventricle. And then from the right ventricle, it leaves through the pulmonary trunk. Now, And the pulmonary trunk divides into the two pulmonary arteries. Remember, there's a very high vascular resistance in the pulmonary circuit, so very little of that blood actually goes out the pulmonary arteries. Almost all of it leaves the pulmonary system and goes through this little connection, this little duct that connects the pulmonary to the aorta, and that's the ductus arteriosus. So that blood crosses the ductus arteriosus to get into the aortic arch. And at that point, it meets up with the blood that's already in the aorta, which was the IVC blood. And so at that point, they mix and end up something in between. And that's the blood that then goes down the descending aorta and distributes to all of the arteries that come off the descending aorta, including the umbilicals, which is where the story started. So the blood that we saw going out the umbilicals at the beginning of the story is this blood. Partially oxygenated blood. Okay? Now, there's an obvious question that we can ask here, which is, if those two flows of blood, the IVC and the SVC blood, are going to end up mixing together at this point where the ductus enters the aorta, so they're going to mix together anyway, why do we go to all the bother of keeping them separate as they flow through the heart? Why not just mix them here in the right atrium and be done with it? Why keep them separate just to have them mix later on anyway? And the answer is that these three arteries that come off the aortic arch, that's the brachiocephalic trunk, the left common carotid, and the left subclavian, they all come off the aortic arch before the ductus comes into the aortic arch, which means those three vessels can only be filled by the IVC blood, the more oxygenated blood. And what those vessels have in common is that they all provide blood supply to the brain. The carotids, that and that, certainly supply the brain, but remember that the subclavian gives rise to the vertebral arteries, which also supply the brain. So the cerebral circulation is entirely being supplied by the more oxygenated blood that came from the IVC. And then after those vessels have been fed, then we can mix the blood together, and the descending aorta on down sort of gets whatever oxygen is left over. So the rest of the body gets less oxygenated blood than the head did. Okay? And that all works because the ductus arteriosus enters the arch of the aorta just after those three branches have left the arch of the aorta. Okay? So that's how this fetus lives throughout prenatal life. And then when the baby is born, what are the changes that occur? Well, we know that the umbilical arteries close down. The adult remnant of the umbilical artery is going to be the medial umbilical ligament. That's not an important feature to worry about. That's what it becomes. If there's no blood going out to the placenta, they're not going to have any blood coming back, so the umbilical vein closes down. The adult remnant of the umbilical vein is going to be the ligamentum teres, or the round ligament of the liver. We'll talk more about that tomorrow when we do the abdomen, but that's the umbilical vein becomes the ligamentum teres of the liver. If there's no blood coming through the umbilical vein, then there can't be any blood to go through the ductus venosus, so the ductus venosus closes down, and that becomes the ligamentum venosum. That's not important to worry about. But the important point now is that the IVC, which is containing venous return, systemic venous return from the lower limbs and pelvis, reaches the right atrium without any other blood mixing in with it. So it's deoxygenated blood entirely, which means that now, postnatally, the IVC blood and the SVC blood are the same. They're the same now, in contrast to what we saw prenatally. They both come into the right atrium. Remember that at birth, this foramen ovale closes because of the reversal of the pressure gradient. So with the closure of the foramen ovale, there's only one way out of the right atrium, and that's through the tricuspid valve to the right ventricle. So all that blood goes to the right ventricle, and then from the right ventricle out the pulmonary trunk. And now, with the baby born and breathing, the vascular resistance in the pulmonary circuit drops. And so now blood is able to go out the pulmonary arteries. So it goes out the pulmonary arteries. And also this ductus arteriosus closes and becomes the ligamentum arteriosum. So that closes, and therefore the blood all goes out the pulmonary arteries to the lungs, gives up CO2, picks up oxygen, comes back, and through the pulmonary veins reaches the left atrium. And then oxygenated blood goes from the left atrium to the left ventricle, and then out the ascending aorta, around the arch of the aorta, and down the descending aorta. So again, in contrast to the prenatal circulation, where the ascending aorta had more saturated blood than the descending aorta, now postnatally the entire systemic arterial system has the same fully oxygenated blood. Ascending and descending aorta is all the same. Okay? Now, I said that the ductus arteriosus closes. But the obvious question is, how did that happen? How did it close? We know how the foramen ovale closed, right? That closed because of the reversal of the pressure gradient. How did the ductus arteriosus close, and how did it know that that was the right time to close? So let's take a look at that. So here's the ductus arteriosus. And prenatally, we said it was sending blood from the pulmonary system into the aortic system. So prenatally, it was following that arrow. In other words, it was a right to left shunt, which is what we'd expect prenatally. Right to left pressure gradient. When you reverse the pressure gradient after birth, that means that the blood will flow from aorta to pulmonary trunk. Okay? So the reversal of the pressure gradient does not cause closure of the ductus arteriosus. The reversal of the pressure gradient just changes the direction of the shunt and converts the ductus from a right to left shunt into a left to right shunt. Right? Reversal of the pressure gradient changes the direction of flow, making it a left to right shunt, which means that if the ductus stays open, you'll be left with a left to right shunt. So that means patent ductus arteriosus is a left to right shunt, meaning it is a non-cyanotic defect. A non-cyanotic defect. So that still leaves us with the question of, if the reversal of the pressure gradient didn't cause it to close, what does cause it to close? And the answer to that is simply that the wall of the ductus, remember the ductus is really just a blood vessel. It's a fancy name, but it's just an artery. And just like every other artery in the body, it has smooth muscle in its wall. And that smooth muscle is arranged in a circular fashion so that when it contracts, it constricts the lumen. That's true for all of our arteries. That's the major mechanism for controlling blood pressure, right? But this smooth muscle that's in the wall of the ductus is a little bit special. So it's given a name. It's called ductal smooth muscle. And two important features about it that make it special. One is that it has the capacity to contract a lot. So when it contracts, it doesn't just contract and narrow the lumen. It contracts and contracts and contracts and contracts until it finally obliterates the lumen, completely closes off the ductus. So closure of the ductus arteriosus is a result of contraction of the ductal smooth muscle. And of course, remember, smooth muscle is a slowly contracting muscle. So closure of the ductus arteriosus is not a rapid event. It doesn't happen immediately at birth. Closure occurs gradually over the first few hours after birth as that muscle is contracting. It's usually closed within the first 24 hours. 48 hours is considered the upper end of normal, but it's usually closed within 24 hours. Okay? So that's how it closes, but we still have the question of how did it know that that was the time to close? Why didn't it close before that or after that? And the answer to that is that the ductal smooth muscle responds to a signal, and that signal is increased oxygen directly because of increased oxygen, which oxygen saturation increases as a result of baby breathing. and also the release of bradykinin by the lungs when the baby starts to breathe, and the bradykinin stimulates the smooth muscle to contract. So both directly and indirectly, the increase in O2 levels causes the contraction of the smooth muscle. So that's why it occurs after the baby is born. But the other thing that also happens is related to the fact that that ductal smooth muscle, there is an inhibitor, let me put it that way, there is an inhibitor to that response that inhibits the ductal smooth muscle from responding to increased oxygen, and that inhibitor is prostaglandin. Prenatally, there are high levels of circulating prostaglandin. And that prostaglandin synthesis decreases at around 9 months of development. In other words, at about 9 months, there is a significant drop-off in the levels of prostaglandin. And so that means that at the time that the baby is born, we have an increase in oxygen tension and a decrease in prostaglandin. So we increase what's stimulating the smooth muscle and we decrease what's inhibiting the smooth muscle. So between the two of them, that leads to closure of the ductus arteriosus. Okay, so that's the mechanism, and that's how it knows to do it then and not sooner or later. That decrease in prostaglandin levels, I said, is something that occurs at about 9 months of development. In other words, it's a timed event at about 9 months of development, which corresponds to about the time of birth. Okay? Now, if we understand that as the mechanism for closure of the ductus, we now have a very nice explanation for why the occurrence of patent ductus arteriosus is much higher in preterm babies than it is in full-term babies. Because in preterm babies, lung development often is not complete, and therefore the alveolar membranes have not thinned out enough, and therefore these babies are hypoxic. And so O2 levels are too low, so we're not stimulating the smooth muscle as much as we should, and because the baby is not at 9 months of development, prostaglandin levels are still too high. So if this is too low and this is too high, not a big surprise that that doesn't close. And that's indeed what we see with a significant frequency in preterm babies. It also explains how you fix that problem in preterm babies. Because since the baby is hypoxic, you're going to be giving oxygen anyway, right? So you're going to give oxygen, so that raises O2 levels. And you can give an inhibitor to prostaglandin synthesis, like indomethacin or any other prostaglandin inhibitor. And so you can lower prostaglandin levels, raise oxygen levels, and then between those two events, that will lead to closure of the ductus. And so usually in preterm babies, that will fix the problem. Now, if it's a full-term baby that has a patent ductus arteriosus, that probably won't work, because in a full-term baby, that's probably not the cause of the patent ductus arteriosus. It was probably a structural cause. So manipulating these factors probably won't fix the problem, and there'll probably have to be a surgical correction. One last point to be made before we leave this topic and then take a break. Let's think back to transposition of the great arteries. And we said that the reason that those babies are alive is because they have other defects that's allowing mixing. Well, you can be pretty sure that one of those other defects is a patent ductus arteriosus. Remember, these babies are very hypoxic. And so if they're very hypoxic, it's not a surprise that the ductus doesn't close. But here's the problem. Because the baby is hypoxic, you have to give them oxygen to protect the brain. If you give them oxygen, that'll probably cause closure of the ductus. And if you close the ductus, it may well kill the baby. Because remember, they're depending upon that shunting to allow survival. So what do? If you want to give oxygen to protect the brain, but you don't want the ductus to close, what do? You elevate levels of prostaglandin. You give prostaglandin, exogenous prostaglandin, infuse it into the baby's circulatory system, keep the prostaglandin levels quite high, so now you can give the oxygen without causing closure of the ductus arteriosus. So it's sort of the flip side of what we said before. If you want to close a patent ductus arteriosus, you inhibit prostaglandin. And if you want to maintain a patent ductus arteriosus, you give exogenous prostaglandin, because prostaglandin is the inhibitor to closure of the ductus. Okay? All right. We can skip that, and now it's a good time to take a break. So let's take 10 minutes, and we'll go on and deal with a variety of adult heart issues after the break. Okay, back to work. So now let's deal with some anatomy of the adult heart. And let's just spend a moment on the pericardium on page 211. We don't have to spend a lot of time on this because we already know most of what we need to know because it's the same as the pleura that we talked about yesterday. So again, there's going to be two layers of pericardium, one on the surface of the heart called visceral pericardium, and the second one outside of that is parietal pericardium. In between the two, there's a cavity called the pericardial cavity. That's the same like the lung. The one important feature that's different is that for the heart we have a third layer of pericardium outside of the parietal pericardium infused with it, and it's called the fibrous pericardium. And what's important about the fibrous pericardium is simply that it is fibrous. It is a very tough fibrous layer which doesn't stretch. And that's the important point. It doesn't stretch. So that means that if you were to have a rapid accumulation of fluid in the pericardial cavity, because the fibrous pericardium doesn't stretch, it won't allow that cavity to expand outward to accommodate that fluid. And if it can't expand outward, then it will expand inward. And by expanding inward, it's compressing the heart. So the fluid in the pericardial cavity will result in compression of the heart. That's called cardiac tamponade, and what that will do is will interfere with venous filling of the atria and then of the ventricles, and it means you'll end up with a reduced end diastolic volume, and therefore a reduced stroke volume and cardiac output, reduced blood pressure, and patients can die from cardiac tamponade. So when there is a rapid accumulation of fluid in the pericardial cavity, that fluid has to be removed to take that pressure off the heart, and that's accomplished by pericardiocentesis. Okay, so that's all we'll say about the pericardium. Looking at the interior of the heart, we already are familiar with some of the interior of the atrium. We already talked about the septum. We already know that part of the inner wall will be trabeculated and part will be smooth, and we know what the embryological basis of that is. The ridges of muscle that make the trabeculated, those ridges of muscle are called the pectinate muscles, and the smooth region is called the sinus venarum because it's derived from the sinus venosus. And as you'd expect, since the sinus venosus is a venous structure, all of the veins that come into the heart enter in that smooth area, in the sinus venarum. Okay, so that's what we see in the atrium. When we look in the ventricle, again, we see part of the wall is rough-walled, part of the wall is smooth-walled. Again, we know what the embryologic significance of that is. An additional feature in the ventricle to be familiar with are these little bundles of cardiac muscle that project upward from the ventricular wall on both right and left ventricles up into the ventricular cavity. These are called papillary muscles. And when you get to the tip of the papillary muscle, we see that there are these fibrous strands that go from the tips of the papillary muscles to the edges of the cusps of the tricuspid and mitral valve. And those strands of cartilaginous tissue are called chordae tendineae. So we have from the ventricular wall, we have papillary muscles extending inward, then we have chordae tendineae, and then those are attached to the leaves of the valves. And what that whole mechanism is designed to do is to, by pulling down on the edges of the cusps of the valves, they control the closure of the valve. They prevent the valve, when the ventricle is contracting in systole, thereby pushing the valve upward, they prevent the valve from going too far upward, thereby preventing prolapse of the valve. Now, if the valve were to go up to close and then keep going, it reopens. And so that would result in an incompetent valve, prolapse. Okay? So it's the papillary muscles and the chordae tendineae that are controlling the closure of the valve and thereby preventing prolapse. That's an important point to keep in mind, because that would mean that if a patient was to have ruptures of the chordae tendineae, and sometimes that's seen with endocarditis, that likely would result in prolapse with regurgitation. Similarly, if the patient had an MI that involved a papillary muscle, that also would result in prolapse with regurgitation. Okay? All right, let's move on and talk about the blood supply to the heart. It's supplied by usually two coronary arteries, a right and a left coronary artery, both direct branches of the ascending aorta. The right coronary artery leaves the right side of the ascending aorta and immediately enters the coronary sulcus. That's why it's called a coronary artery, because it's in the coronary sulcus. And remember, the coronary sulcus goes all the way around the heart, so we see the right coronary artery staying with it going around the heart. Now remember, the coronary sulcus is also called the atrioventricular sulcus because it separates atrium from ventricle. So what that means is that the right coronary artery is sitting right between right atrium and right ventricle. And so, therefore, not a surprise, what it supplies is the right atrium and right ventricle. For all of these arteries, as long as you know where the artery is, you automatically know what it supplies, because it just supplies the immediate surrounding neighborhood. Okay? As you follow the right coronary artery around the back of the heart, it gives off a branch that goes into the interventricular sulcus, called the posterior interventricular artery. So since it's in the interventricular sulcus, it's supplying the two ventricles, the right and left ventricles, on the posterior side, and as well as the posterior part of the septum. The left coronary artery comes off the left side of the aorta. It's pretty short, it's only about 1 inch long, just long enough to get past that pulmonary trunk, which is 1 inch wide, just to the left of the aorta. And as soon as it gets past the pulmonary trunk, the left coronary divides into two branches. One branch is the circumflex branch of the left coronary, and that's the artery that enters the coronary sulcus on the left side. And again, stays in the coronary sulcus, goes around the back of the heart. Now here, the coronary sulcus is separating left atrium from left ventricle, and so therefore the circumflex is supplying left atrium and left ventricle. And we see that since the circumflex is in the coronary sulcus, we've already said the right coronary is in the coronary sulcus, we see how those two arteries are sort of coming at one another from opposite directions. So certainly we see the opportunity for collateral channels to develop between those two vessels, and that provides a left coronary to right coronary pathway for collateral flow by way of the circumflex artery. So that's important. You have the opportunity that if you were to have a partial occlusion of the right coronary artery, you can see that the left coronary can take over, by way of the circumflex, can take over supplying the territory of the right coronary. The other branch of the left coronary is the artery that goes into the interventricular sulcus on the anterior side, the anterior interventricular artery, which is more commonly called the left anterior descending artery. So it sits in the interventricular sulcus, so it's supplying left and right ventricles on the front of the heart. Stays in the sulcus, wraps around the back of the heart, in that sulcus where it meets the posterior interventricular. So again, we have an opportunity for collateral flow between a branch of the left coronary and a branch of the right coronary. Okay, so the same reason that of importance applies to that as well in terms of collateral flow. Okay, so that's the basics of the coronary circulation. One little fact to keep in mind is that the two nodes, the SA node and the AV node, which we're going to talk about shortly, both usually, not always, but both usually get their blood supply from branches of the right coronary. So occlusions of the right coronary are more apt to affect the conduction system. Now, If there's an arterial system, there must be venous drainage, and so there are cardiac veins. They're called cardiac, not coronary veins, but cardiac veins. And there are multiple cardiac veins. It's not important to know about the individual cardiac veins, but take note of the fact that almost all of the cardiac veins, almost all, not all, but almost all of the cardiac veins end up draining into one large vein. That's on the back of the heart between left atrium and left ventricle in the coronary sulcus, and that large vein is called the coronary sinus. Okay, you see multiple veins draining into the coronary sinus, and then the coronary sinus drains directly into the right atrium. Okay, into the right atrium. So remember that the right atrium receives 3 large veins, not just the 2 vena cavae, but also the coronary sinus. Okay? So that's the venous drainage. So now let's turn our attention to the cardiac conduction system. And in order to understand the cardiac conduction system, it's important that we start off by understanding a little bit about cardiac muscle, and more specifically what makes cardiac muscle different from skeletal muscle. There are a lot of similarities between the two. They both have polarized membranes, they both have thick and thin filaments. When they depolarize, when the membranes depolarize, you have a calcium flux, calcium binding, and sliding of the filaments past one another. All of that's the same. We're not going to get into those details. There are 2 really important differences that apply to this discussion. The first is that skeletal muscle cells are electrically isolated from their neighboring skeletal muscle cells. So one skeletal muscle cell has no electrical communication with a neighboring cell. So that if one cell depolarizes, the cell next to it doesn't know anything about it. And it doesn't depolarize. And if it doesn't depolarize, it doesn't contract. And so you have electrical isolation of skeletal muscle cells one from another. Cardiac muscle cells, on the other hand, are electrically communicating with their neighboring cells. There are membrane specializations that are called gap junctions, and they're found at the intercalated discs of the cardiac muscle cells. And that means that when one cardiac muscle cell depolarizes, the neighboring cell will also depolarize. Okay? So that's an important difference. The other important difference is that skeletal muscle cells have polarized membranes that stay polarized unless something is done to them to depolarize them. And usually what's done to them is that the nerve that innervates them fires, acetylcholine is released at the synaptic junction, and then that sets up a cascade of events that leads to depolarization. But if that nerve doesn't fire, or if that nerve is damaged so that it can't fire, that muscle won't depolarize and therefore it won't contract, which is why if you cut the nerve going to a skeletal muscle, that muscle is paralyzed. On the other hand, cardiac muscle cells have polarized membranes, but they spontaneously depolarize. If you just leave them alone, they will depolarize and then they repolarize, and they depolarize and then they depolarize. Okay, and every time they depolarize, they contract. So cardiac muscle spontaneously contracts, not requiring any innervation to do that. Okay, so that's another important difference. So now if we think about the nature of the muscles of the heart, realize this: all of the cardiac muscle cells are spontaneously depolarizing. But they are each an individual cell, and so that means they each have their own intrinsic rate at which they want to depolarize. One cell may want to depolarize at 45 times a minute, another one may want to depolarize at 40 times a minute, another one may want to depolarize at 42 times, another one at 37 times, and so forth. However, all of these cells are electrically communicating with one another. So that means when any of the cells depolarize, all of them depolarize. So when you put those two thoughts together, you have all these cells that are spontaneously depolarizing, but they're at different rates. But because they are all electrically communicating, when any of them depolarize, all of them depolarize, that would then lead to the question of what determines the rate at which they depolarize. And the answer to that question is whichever cells are depolarizing the fastest would cause all the other cells to depolarize at that rate. In other words, if one cell, if you just left it alone, likes to depolarize at 45 times a minute, but there are some other cells that like to depolarize at, let's say, 70 times a minute, and that's the fastest of any of the cells in the heart, then all the cells are going to depolarize at 70 times a minute, even if they wanted to depolarize at a much slower rate, because they're being forced to by that fastest depolarizing cell. And so those fastest depolarizing cells are going to be called the pacemaker cells. And the pacemaker cells are going to be accumulated together in a structure known as the sinoatrial node. The sinoatrial node, which we see right here, it's in the wall of the right atrium, right at about the point where the superior vena cava enters the right atrium. That's where the SA node is. And what makes the SA nodal cells special is that they are specialized cardiac muscle cells that depolarize faster than any other cardiac muscle cell, and therefore the SA node is the pacemaker for the heart. Okay? Now, when I said that cardiac muscle cells electrically communicate with all the other cardiac muscle cells, that's not quite accurate. It would be more accurate if I said that atrial cells all depolarize, all communicate with one another, or if I said all ventricular cells communicate with one another. But atrial cells don't directly communicate with ventricular cells because there is a layer of dense connective tissue that runs across the heart at the junction between atrium and ventricle, a layer of dense collagenous connective tissue, and that's called the fibrous skeleton of the heart, the cardiac skeleton. Now, that structure has some mechanical purposes to it in terms of having muscle attached to it, but that's not the point that I want to talk about now. The important point is that this is fibrous, and therefore it has almost no membrane in it, and it acts like a layer of insulation. And because of that layer of insulation, atrial cells are not electrically communicating with ventricular cells. And so that means that the sinoatrial node is going to drive all of the atrial cells, because they're all electrically communicating, it's going to drive all of the atrial cells to depolarize at the SA nodal rate. But the ventricular cells would not get that information and wouldn't know anything about it, and they would go on their way depolarizing at some other rate that's slower than the SA node. So that's not very good. We can't leave it like that. We can't have the ventricles depolarizing at a rate slower than the atrium. That would be very inefficient. So how do we fix that? Well, it turns out that fibrous skeleton has one point in which it's sort of like has a hole in it. There's a defect in it. And passing through that defect is a bundle of specialized cardiac muscle cells that are called the atrioventricular bundle, or the bundle of His, or the common bundle. All means the same thing. And it's a bundle of cardiac muscle cells that traverse from the atrial septum into the ventricular septum by going across that defect in the fibrous skeleton. And so because of that AV bundle, we now have electrical communication between atrium and ventricle, because once we get that signal into the ventricle, to any ventricular cells, because they're all communicating with one another, we're able to communicate with all the ventricular cells. And so because of the AV bundle, the SA node is now able to drive not only the atrial cells, but also the ventricular cells. So we solved that problem. But there's still a different problem that we're left with. If we don't add something else to the story, we would now have the ventricles not only depolarizing at the same rate as the atria, but they'd also be depolarizing at the same time as the atria. In other words, we would have simultaneous atrial and ventricular systole. And that's not good. We don't want that. We want the ventricles contracting a little bit after the atria contract in order to allow time for the ventricles to finish filling before they contract. So how are we going to accomplish that? Well, at the upper end, at the atrial end of that AV bundle, there's a group of specialized cardiac muscle cells called the AV node. And two important things for us to know about the AV node. The first is that the only electrical pathway into the AV bundle is through the AV node. So a depolarization that may have arisen from the SA node, if it wants to get into the AV bundle to get to the ventricle, has to go through the AV node. It's the only way in. And then the second important thing is that the AV node has as its character, the cells of the AV node has as its characteristic the fact that the velocity of propagation, the speed at which a depolarization propagates across the AV node, is much slower than any other cardiac muscle. Velocity of propagation is much slower across the AV node than any other cardiac muscle. So what that means is when the SA node depolarizes, that depolarization very rapidly spreads across all of the atrial cells, including the AV node, but then it goes very slowly across the AV node, finally gets into the AV bundle, speeds up again, and goes on down into the ventricle. The AV bundle splits into right and left bundle branches and then spreads out to all of the ventricular cells. The important point is that this depolarization was very slow in crossing the AV node. And because of that, by the time it got into the AV bundle and then into the ventricle, it's a little bit later than when it spread across the atria, because it was slowed down crossing the AV node. And because of that, we now have the ventricles depolarizing at the same rate as the atria, but not at the same time. There's a lag time built in caused by the AV node. And so if we translate all of that to the familiar electrocardiogram, I'm sure you all know that the P wave represents atrial depolarization, and the QRS represents ventricular depolarization, and you see that there is a lag time between the P wave and the R wave. And you can see it's about 0.15 seconds, and that lag of about 0.15 seconds is what was imposed by the AV node. So realize the more that the AV node slows down the propagation, the longer that PR interval will be. The less the AV node slows down the propagation, the shorter the PR interval will be. So we're saying that the SA node controls how many times per minute we see this cycle, and the AV node controls the lag between atrial depolarization and ventricular depolarization, the so-called PR interval. Okay? Now, recognize that throughout that discussion, we didn't use the word nerve at all. My point here is that none of this, the SA node, the AV node, the AV bundle branches, none of that is made up of nerve tissue. It's all made up of specialized cardiac muscle. The point being that all of this operates just fine without any nerve innervation. You don't need nerve innervation to have a cardiac cycle. And you all are familiar, I'm sure, with the fact that if you take a heart out of an animal, and as long as you keep the heart oxygenated and nourished, it will keep beating. And clearly, if you've taken the heart out of the animal, it's not innervated. So it doesn't need an innervation to keep beating. But the fact that it doesn't need an innervation doesn't mean it doesn't have an innervation. The heart has a very robust innervation. It has sympathetic innervation, it has parasympathetic innervation, and it has sensory innervation. The sympathetic and parasympathetic innervation, in other words, the motor innervation, what's its function? And we've already said that its function is not to cause the cardiac cycle, but what it does do is it modulates the cardiac cycle. So that, for example, we said that the SA node, let's say if we just left the SA node alone, it would be depolarizing at about 70 times a minute. But if I need the SA node to depolarize faster than that because I'm exercising and I need a faster heart rate, I need to be able to tell the SA node to speed up. And my sympathetic innervation does that. If I want to tell the SA node to slow down, my parasympathetic innervation does that. If I want to shorten the PR interval, my sympathetic innervation tells the AV node to retard the propagation a little bit less. If I want to lengthen the PR interval, my parasympathetics tell it to increase the retardation. Okay, and a variety of other things as well. Excuse me. So the sympathetic and parasympathetic motor innervations modulate the cardiac cycle. They don't cause the cardiac cycle. The sensory innervation also has an important role. There are two pathways for sensory innervation. One pathway parallels the parasympathetic innervation, the other pathway parallels the sympathetic innervation. So the pathway that parallels the parasympathetic, remember parasympathetic innervation to the heart is from the vagus, so that means that there are sensory fibers going back from the heart in the vagus, which means that they're going back to the brainstem, to the medulla. And these sensory fibers that reach the medulla then eventually will end up in the reticular formation, in the portions of the reticular formation in the medulla and pons that control cardiovascular function. So what fibers are sensory fibers that are the afferent limbs, the sensory limbs for the cardiac reflexes. And information in those sensory fibers does not reach conscious levels. Okay? Doesn't go up to the cortex. So you don't have any conscious awareness of sensation being brought back from the heart through the vagus. No, it's measuring things like wall pressure and CO2 levels and oxygen tension and stuff like that. Nothing that you would have any conscious awareness of. The other sensory fibers, the ones that parallel the sympathetics, since the sympathetic innervation comes from the upper thoracic cord, remember sympathetics come from T1 to L2. Sympathetics to the heart come from the upper thoracic, T1, T2, T3, T4. And so these sensory fibers go back to the spinal cord at levels T1, T2, T3, T4. Okay? They enter the spinal cord through the dorsal roots. The cell bodies of the dorsal root ganglia. After going into the dorsal root, they then synapse like any other sensory fiber will do, and then there are ascending fibers that go up and eventually will reach conscious levels. So this is sensation that's coming back that does reach conscious levels. So what kind of things are they measuring that has a conscious, that's going to give you conscious sensation? And what those sensory fibers are there for is to monitor the myocardium to determine whether the amount of oxygen being supplied to the myocardium is sufficient to support the amount of work being demanded of the myocardium. In other words, if the myocardium is getting an insufficient oxygen supply, that is to say, if the myocardium is ischemic, these sensory fibers let your central nervous system know that you have an ischemic myocardium. That reaches conscious levels. You have a sensation associated with myocardial ischemia, and that's called angina or angina. And so the sensory fibers that reach the upper thoracic spinal cord, they run with the sympathetics, they reach the upper thoracic spinal cord, are the fibers responsible for that. And since they're reaching the upper thoracic spinal cord, the brain interprets those sensations as coming from upper thoracic dermatomes, T1, T2, T3. And so the brain interprets that sensation as coming from the chest wall, from the chest, and from the upper limb, which is where medial side of the upper limb, which is where the T1 dermatome is. So that's why pain associated with myocardial ischemia or even with the myocardial infarct is perceived as chest pain and upper limb pain. Okay, that's all I'll say about that. And so now let's finish up the thorax by dealing with those elements of the mediastinum that we haven't yet covered. So firstly, what is the mediastinum? The mediastinum is the region within the chest, within the thorax, between the two pleural cavities. So on this diagram, imagine that you have a pleural cavity here surrounding a lung and another pleural cavity here surrounding a lung. And so everything that's in between the two pleural cavities is the mediastinum. And for descriptive purposes, we divide the mediastinum into an upper part and a lower part by, before we get to that, let me just show you mediastinum in cross-section. So there's a pleural cavity surrounding a lung, there's a pleural cavity surrounding a lung, and then everything in between all of this is mediastinum. So we divide the mediastinum into two parts, an upper part and a lower part, by making an imaginary horizontal plane at the level of the manubriosternal junction on the sternum. And if you run that plane straight back until it hits the vertebral column, it'll hit the column at the bottom of T4. And we say the mediastinum that's above that plane, we're going to call that superior mediastinum. And then below that plane, you could call it the inferior mediastinum, but we don't, because we then take that part below that horizontal plane and we divide it into three parts. And we use the pericardium as the landmark. And we say anything that's within the pericardium, we're going to call middle mediastinum. If it's in front of the pericardium, we're going to call it anterior mediastinum. And if it's behind the pericardium, we'll call it posterior mediastinum. So the four parts of the mediastinum for descriptive purposes are superior, anterior, middle, and posterior. And remember, this horizontal plane is imaginary. There is no structure there that separates superior from inferior. We just made that up. Okay? Now, we've been talking about the stuff that's in the middle mediastinum, so we don't have to do that anymore. There's nothing worth discussing in the anterior mediastinum, so we won't. So that just leaves us with the superior mediastinum and the posterior mediastinum. So let's start off with the superior mediastinum. And looking at it from this lateral view, you can see that the superior mediastinum has an anterior wall, which is the manubrium, and it has a posterior wall, which is the vertebral column. And then between those two walls, we have a series of structures that seem to be laid out in layers as we go from posterior to anterior. And so that's a useful way to think about structures in the superior mediastinum as being organized into layers, specifically 5 layers of structures, with the first layer being most posterior right on the vertebral column, and then things laid out in front of it until we get to the front. So let's look at it that way. From the front, put in that imaginary horizontal line at the level of T4. So now we're talking about all this stuff up here, the superior mediastinum. So the most posterior layer is this right here, and that's the esophagus. Okay, so that's layer 1, the esophagus. In front of the esophagus is layer 2, and that's the trachea. Now, recognize that the esophagus doesn't stop when we reach that imaginary plane. The esophagus just keeps right on going, passes behind the heart, comes out from below there, goes through the diaphragm, and goes on into the abdomen. Okay. In contrast, the trachea just so happens that the trachea divides. It ends at T4. So it doesn't get past that imaginary plane. It gets down to T4. That's the end of the trachea. It divides into 2 bronchi that leave the mediastinum and go into the lungs. So that's layer 2. In front of layer 2, layer 3 is called the arterial layer, and it's made up of a total of 6 arteries. The 6 arteries that make up the arterial layer are 3 parts of the aorta. They're given 3 separate names, so we count them as 3 arteries. The ascending aorta, aortic arch, and the beginning of the descending aorta. And then 3 branches of the aortic arch, the brachiocephalic trunk, the left common carotid artery, and right there and continuing there is the left subclavian artery. So we have 3 parts of the aorta, ascending arch and descending, and 3 branches of the aortic arch, brachiocephalic, left common carotid, left subclavian. So those 6 collectively make up layer 3. They're in front of the trachea, so they're layer 3. In front of layer 3 is layer 4, which is the venous layer, and the venous layer is made up of the superior vena cava and its 2 branches, 2 brachiocephalic veins. And you can see here that the veins are in fact in front of the arteries. That's why it's layer 4. And in front of the veins would be layer 5, which is not shown on this diagram. It's been removed. Layer 5 is the thymus. Okay, it's been removed so you can see everything else, but layer 5 would be in front of the veins. Okay, and then in front of that, of course, would be the manubrium. So those are the structures of the superior mediastinum that you should pay attention to. Working from the back to the front, you have esophagus, then trachea, then arteries, then veins, then thymus. Okay, we'll deal with that a little bit more in a few minutes, because by organizing it into those 5 layers, that's how we're going to identify the structures in a CT scan at the level of the superior mediastinum, by recognizing those 5 layers. Okay, so here you can see that again. Esophagus, trachea is not shown here, then arteries, then veins, thymus would be here, and then manubrium. The posterior mediastinum has only a few things in it, and 2 of them are important enough to mention: the esophagus and the descending aorta. So firstly, the esophagus. Now, we saw the esophagus in the superior mediastinum, okay, and we said it was the most posterior structure. In the posterior mediastinum, the esophagus is now the most anterior structure in the posterior mediastinum, which means it's right up against the back wall of the middle mediastinum. And the back inside the middle mediastinum is primarily the heart, and the back wall of the heart is the left atrium. So what we're saying is that the front wall of the esophagus is right up against the back wall of the left atrium. That's an important relationship to keep in mind. That certainly is the anatomical basis for why transesophageal echocardiography is such an excellent imaging method for cardiac imaging. Because if you put an ultrasound transducer down into the thoracic esophagus, you see that that transducer is now sitting directly behind the heart with no bony tissue intervening, so you're able to get excellent imaging of the heart, and particularly excellent imaging of the left atrium and the mitral valve. So TEE is a really good imaging methodology, but it's that anatomical relationship that explains that. Similarly, we can understand why left atrial enlargement in a patient will often present with dysphagia, because the enlarged left atrium will compress the esophagus. Okay? And then the other important structure in the posterior mediastinum is the descending aorta. We saw the beginning of the descending aorta in the superior mediastinum, and then it just continues right on through the entire length of the posterior mediastinum. And then we'll go through the diaphragm and end up in the abdomen as the abdominal aorta. And notice that the descending aorta is posterior and to the left towards you on this diagram, posterior and to the left of the esophagus. That's how you'll recognize it. Okay? We can skip that. Okay. So now let's take everything that we've done in the thorax and put it together to help us interpret CTs of the chest. And we'll use these CTs to review much of what we talked about in the chest. So we'll start with this CT that's on page 227. This is probably the most common chest CT that would appear on an exam. And what's so nice about it is that it's right through all of the chambers of the heart. So a lot of things you can ask about here. But before we get to looking at the specifics, let's remind ourselves of how you look at a CT. So when you're looking at a CT, imagine that the patient is lying on a bed, supine. His back is on the bed, belly up. You're standing at the foot of the bed looking up into the patient from his foot, from the feet and up in, looking up from below. So that means the patient's anterior side is on the top, posterior side is on the bottom. Patient's right is on your left, patient's left is on your right. That's how you'll always look at an axial CT or an axial MRI. That's always the orientation. Okay? And it's really helpful if until you get really familiar with reading CTs, that you always start off by just getting your orientation, just the way we did it. Remind yourself that this is anterior, this is posterior, this is right, and this is left. So if we point to this, that means that's a lung field, so that tells you this is the right lung. And that means this is the left lung. If we point to this part of the right lung, this anterior portion of the right lung, we know that that's the right upper lobe, because remember the upper lobe is anterior. Okay, because of the oblique fissure is oblique. So this would be the right upper lobe, and this would be the left upper lobe. That means this would be the left lower lobe, posteriorly. And this would be the right lower lobe, posteriorly. Well, if this is the right upper lobe, and this is the right lower lobe, that means this would be the right middle lobe. Okay? So that's all there is to that. That's really very simple. Now let's turn to the heart. Now try to ignore these labels for a few moments, because that's not going to help you if you just read the label. If I point to this part of the heart and ask you which chamber is it, what chamber and how do you know? And the answer is it's the right atrium, and the way you know it's the right atrium is because this is the right border of the heart. Right? This is the right side of the patient, this is the right lung, so this is the right border of the heart, and we've said that the right border of the heart is entirely right atrium. So that's right atrium. If I point here to the left border of the heart, that must be the left ventricle. Okay, so again, remembering this is left side, left lung, left border of the heart is left ventricle, so that's the left ventricle. If I point here, that's the anterior wall of the heart. This is the anterior side of the patient, so that's the anterior wall of the heart. We know the anterior wall of the heart is right ventricle, and posterior wall of the heart we know is left atrium. Okay, so that's those really important landmarks that we talked about at the end of the day yesterday. That's how you do that. Okay. We just finished saying that the structure that's immediately behind the heart, at the posterior wall of the heart, is up against the anterior wall of the esophagus. So that's how we know that that's the esophagus. You see the anterior wall is right up against the posterior wall of the left atrium. So that's the esophagus. And we said that the descending aorta is going to be posterior and to the left. Remember, this is left. Posterior and to the left of the esophagus is the descending aorta. So that's the descending aorta. Okay. This is not labeled. What would that be? What would that be? Sternum. Okay, that's a good answer. But what if I asked you which part of the sternum? Manubrium or body of the sternum? Manubrium or body? Okay, most of you are saying body, some of you are saying manubrium. It is the body of the sternum. And how do we know it's the body of the sternum? Because we know we're below T4. Remember, the manubriosternal junction is a T4. And how do we know we're below T4? Because we see a heart in the picture. Not because it says T6 up here. On the exam, they're not going to tell you that it's T6. But if you see a heart in the picture and you know the heart is in the middle mediastinum, that means you're below T4. And if you're below T4, that has to be the body of the sternum. Okay? All right, let's take a look at this CT. So this, we're in the chest. We see two lungs, but we don't see a heart. So that tells us we're above the heart. So that means these structures must be structures of the superior mediastinum. And so we know how to interpret superior mediastinal images because we just went through those 5 layers of the superior mediastinum. And that's how we're going to do this. So we said the superior mediastinum has a posterior wall, which is the vertebral column, and an anterior wall, which is the manubrium. Now this is manubrium. No heart in the picture. It's manubrium. We're above T4. And then between this vertebral column and the manubrium, we have a series of structures. The first one, most posterior, is going to be esophagus. In front of esophagus, layer 2 is going to be trachea. In front of trachea is going to be arteries, the arterial layer. But now the question is, which arteries? We said that there were a total of 6 arteries. But if we look at this diagram, we see all 6 arteries in any single cross-section. Depending upon where the cross-section is, you'll see some different combination of arteries. And to be more specific, a cross-section through the superior mediastinum is either going to be above the aortic arch, or at the aortic arch, or below the aortic arch. So we use the aortic arch as sort of our landmark, and we say, are we above it, are we at it, or are we below it? If we're above it, and this dotted line tells you where this section is, if you're above it, then that cross-section won't include the aortic arch or the ascending and descending aorta, but it will include the 3 branches of the aortic arch. And so that's what we see here. 3 branches. 1, 2, 3. 1, 2, 3. Okay? The first one is right in front of the trachea. The second one is a little bit to the left of the trachea. And the third one is either further posterior and to the left. So that's brachiocephalic, left common carotid, left subclavian, in that order. And then the venous layer at that level is going to have the 2 brachiocephalic veins. There's the right brachiocephalic vein, which is just the upward continuation of the SVC. And there's the left brachiocephalic vein, sort of streaking across in front of the brachiocephalic trunk, the veins in front of the artery. And then in front of that, we see some grayish material, which is the remnants of thymus. And then in front of that, we see the manubrium. Okay, so esophagus, trachea, arteries, veins, thymus. Now, if we go down a little bit lower, so that the section is at the level of the aortic arch, before we look at that picture, what should we anticipate? We should anticipate that the esophagus will stay right where it is, the trachea will stay right where it is. But as far as the arteries are concerned, instead of seeing the 3 branches of the aortic arch, we should see the aortic arch. And instead of seeing the 2 brachiocephalic veins, we should see the superior vena cava. So let's see if that's true. Okay, now down at the level of the aortic arch, the esophagus stays right where it is. Trachea stays in the same place. But now instead of seeing 3 arteries, we see 1 big structure, and that's the aortic arch. And then just to the right of that is the superior vena cava. That's thymus, manubrium. If we go down a little bit lower, so we're below the aortic arch, again, the esophagus and trachea should stay in the same place. But for arteries, we won't see the branches, we won't see the arch. This time we'll see the ascending and descending aorta. And we'll still see the SVC. So let's say, okay, there's the esophagus, there's the trachea. You see it's gotten really wide here because we're just about the end of the trachea. It's getting ready to bifurcate. It's widening out to bifurcate. Okay, and then where let me just back up a second. In the same place where we saw the aortic arch in the preceding section, okay, now at the front end of the arch, that would be replaced by the ascending aorta. The back end of the arch would be replaced by the descending aorta. That's what we see. There's the ascending aorta. There's the descending aorta. the SVC stays in the same place. Okay, that's pretty easy, right? Okay. Well, I would suggest we have some questions we can go over, but why don't we take a break for 10 minutes? When we come back, we'll do questions for about 10 or 15 minutes, or we'll see how many questions we can get through, and then we'll use the last half hour to start on the abdomen. Okay, so let's take 10 minutes. Okay, here we go. During the break, I noticed on the chat board that some of you were asking whether you should anticipate that they would tell you the level of a CT on the exam, and the answer is no. Don't anticipate being told what level it is. You should be able to recognize what level it is based on the structures that you see in the CT, not the other way around. So, for example, on this CT, you would know that you're above T4, you're in the chest, you're above T4 because there's no heart, but you're very close to T4 because you're below the aortic arch. That's how you would recognize that. But they're not going to ask you what level it is, so the idea is not to know the name of the level. They're going to ask you about the structures, so either to identify the structure or ask you, present you with some clinical scenario and then ask you which structure is most likely involved. Okay. All right. So let's do some questions. Can we bring the poll pod into view? And we'll just go through a few of these. I don't see the poll pod moving, so I'll do it myself. Okay. So, if a patient has had a myocardial infarct that has damaged the common AV bundle sufficiently so that it is unable to function at all, which of the following would you most likely see in this patient? Ventricular systole occurring at a rate faster than atrial systole, ventricular systole at a rate slower than atrial systole, cardiac arrest with complete asystole, different rates of atrial systole in the right and left atria, different rates of ventricular systole in the right and left ventricles. Okay, that's a few more seconds, and we will end the poll. And the correct answer is B. So a little over half of you got that right. That's a little disappointing. So recognize that if the AV bundle is damaged, that means the SA node will be driving the atrial cells, but not the ventricular cells. And since the SA node is the fastest depolarizing structure in the heart, that means the ventricles would be depolarizing at a rate slower than the atria. So B is the correct answer. What this question is, what this question is describing is what clinically is known as third-degree heart block. That's exactly what that would be. Okay, so let's clear the poll and go to the next question. If during development the septum primum and the endocardial cushion fail to fuse, which of the following will result? Persistent truncus arteriosus, patent foramen ovale, a ventricular septal defect that is acyanotic, an atrial septal defect that is acyanotic, shunting of blood from the left side of the heart to the right side of the heart in the prenatal fetus. Okay. A few more seconds. 5, 4, 3, 2, 1. Okay. And the, let's see how you did here. Oh, about 2/3 of you chose D, and that is the correct answer. Atrial septal defect that is acyanotic. Remember, septal defects are acyanotic. What's being described here is which kind of atrial septal defect? Primum type or secundum type? Which is it, primum or secundum? Primum, correct, primum type. Failure of the primum septum to fuse with the endocardial cushion. It is a primum defect. Okay. Okay, let's go to the next question. If your patient has a septal defect in his heart with no other structural heart defects and presents with cyanosis, it is likely that the patient has a primum type ASD, a secundum type ASD, a ventricular septal defect, a pulmonary hypertension, or portal hypertension. A few more seconds. 3, 2, 1, end. And that's an interesting distribution. We have B, C, and D seem to got a lot of choices. And the correct answer is D, pulmonary hypertension. The point of this question is, of course, that both atrial and ventricular septal defects are not cyanotic defects, but this patient is cyanotic. So if you have only a septal defect and it is cyanotic, that must mean that there is something causing a right to left shunt instead of the usual left to right shunt, which means that the patient has pulmonary hypertension. Okay? All right. Let's go to the next question. As a result of an endocardial infection, your patient suffers a rupture of the chordae tendineae of the right ventricle. This is likely to result in an alteration of blood flow that will cause a diastolic murmur that is heard best on the right second intercostal space at the sternal border, a systolic murmur that is heard best at the left second intercostal space at the sternal border, a systolic murmur that is heard best at the right fifth intercostal space at the sternal border, a diastolic murmur that is heard best at the left fifth intercostal space at the sternal border, a systolic murmur that is heard best at the left fifth intercostal space at the midclavicular line. Okay. A few more seconds, and we will end it. Okay. We've got answers all over the place. And the correct answer is C. So a little over a third of you got that right. So this is a typical, what's called a two-step or a jump question, where you have to know one thing and then use that to get to the second thing. So the first thing you need to know is what will that rupture of the chordae tendineae cause? And then the second thing is, where would you hear the murmur resulting from that? So rupture of the chordae tendineae on the right ventricle would result in prolapse of the tricuspid valve. So you'd have an incompetent tricuspid valve, or tricuspid insufficiency. Since the tricuspid valve is closed, should be closed during systole, that would mean you would have a systolic murmur. So that eliminates choice A and choice D. So that brings us to B, C, and E. And so a systolic murmur from the tricuspid valve would have regurgitation back to the right atrium. So it has to be on the right side of the sternum where the atrium is, so that's choice C. Okay. Okay. The choice B, systolic left second intercostal space, that would be over the pulmonary trunk. That clearly is wrong. And choice E, left fifth intercostal space at the midclavicular line, that means over the left ventricle. So that's no good. So C is the correct answer. Okay, let's try another one. An ultrasound of a fetus at 20 weeks of gestation reveals that both ventricles are flowing into a common outflow vessel. The developmental basis of this defect is a failure of the endocardial cushions to form, a failure of the aorticopulmonary septum to form, a failure of the septum secundum to form, a failure of the septum primum to form, a failure of the septum spurium to form. Okay, this one you seem to be getting pretty easily, so we'll end this one pretty quickly. About 3/4 of you got that one right, so that's good. And the correct answer is B, failure of the aorticopulmonary septum to form. If both vessels, both chambers are emptying into a common outflow, that means you have a persistent truncus arteriosus, which is the absence of the aorticopulmonary septum. Okay. I'm going to skip this one. This one usually takes too long. So let's go to this one. Now I'm going to skip that one. So no, I don't like that question. That's not a typical clinical question. Let's try this one. I like this one. During exercise, your patient is experiencing retrosternal pain. The nerve fibers that carry the impulses that are responsible for the painful sensation associated with cardiac ischemia, angina pectoris, have their cell bodies in the dorsal root ganglia, synapse in the cardiac plexus, synapse in the paravertebral ganglia, are within the right and left vagus nerves, have their cell bodies in the wall of the myocardium. Okay, 3, 2, 1, and okay, and A is the correct answer, and about 42% if you got that right. So that's not too bad. So here's the point. Choice B and C and E are, all three of those are describing motor pathways. B would be parasympathetic, C would be sympathetic, E would be parasympathetic. So those are motor pathways to the heart. So that wouldn't be carrying sensory information. A and D are both, well, let's get to the correct answer. The correct answer first. This conscious sensation of ischemia, remember, reaches the upper thoracic spinal cord. That's why it's perceived in the chest and upper limb. And if it's going to go into the spinal cord, it has to go through dorsal root. And therefore, its cell body has to be in a dorsal root ganglion. There are sensory fibers that are in the right and left vagus nerve. So that part would be okay, that there are sensory fibers in the vagus nerves, but those sensory fibers don't carry conscious sensation. Those are carrying the unconscious sensory afferents of cardiac reflexes. So A is the correct answer. Okay, I think maybe we will stop. Yeah, let's just go on and start on the abdomen. Okay, so let's get this out of the way. So in the abdomen, we're going to start on the abdominal wall, and we'll start on that this evening. Our focus on the abdominal wall will be almost entirely on the inguinal region. So we'll look at the inguinal canal, we'll talk about the descent of the testes, and then that'll lead us into a discussion of inguinal hernias. And then we'll move on to the GI tract, the digestive system, and we'll talk about development and the adult and abnormal development leading to congenital defects, and then the normal adult anatomy. We'll do that all together, going back and forth between the embryo and adult continuously, and that we'll be doing tomorrow. And then we'll do the kidneys and ureters, and again we'll do the adult anatomy and the development side by side. Okay. Again, I'll remind you, if you haven't picked up the handout and printed it out, you will need it for tomorrow when we do the digestive system. Okay, so let's get started on the abdominal wall. Firstly, let me just point out to you on page 232 that we divide up the abdominal region into 9 descriptive regions, 3 of them in the midline, epigastrium, umbilical, and hypogastrium, and then 6 of them on the 3 on the right, 3 on the left lateral sides, called hypogastrium, lumbar, and inguinal. So first point I want to make is simply that inguinal is the name of a region. It's the name of a neighborhood. And so we're going to be talking about the inguinal region, and in that region there are a lot of things that have the word inguinal as part of their name. Don't let that all confuse you. We'll be throwing around a lot of inguinals, but it just means they're all living in the same neighborhood. They don't necessarily have much to do with one another. Sometimes they do, sometimes they don't. They just happen to be in the same region. The 3 midline regions, these are going to be important for us tomorrow when we talk about the GI tract, because pain arising from the GI tract is referred to the midline. Okay, that's where GI tract pain comes from. And then depending upon which part of the GI tract, which embryonic part of the GI tract, foregut, midgut, or hindgut, and we'll talk about what that means tomorrow, that will determine where in the midline the pain gets referred to. So pain arising from foregut organs is referred to the epigastrium, pain arising from midgut organs is referred to the umbilical region, pain arising from hindgut organs is to the hypogastrium. So when you're reading a clinical vignette and it describes, a patient presents with epigastric pain, that immediately, very quickly narrows down the possible organs that are the source of that pain. The only pain organs that would give you epigastric pain are foregut organs. So if you know which are the foregut organs, you've really narrowed it down tremendously right away. And same thing for umbilical, for midgut organs, and hypogastrium for hindgut organs. So when we get to this tomorrow, just remind yourselves of where those 3 regions are when we talk about it. Okay, let's talk about the wall now. And in order to understand the inguinal region, we need to know what the layers of the abdominal wall are. They're listed in a little marginal note on page 233, but I'm going to expand on what that says in the book just a bit. So let's start from the outside and work our way in. The first layer is skin. Not a surprise that the first layer everywhere is skin. And then next layer, number 2, is just under the skin, is superficial fascia. That's not a big surprise. That's always right under the skin. In the lower abdominal wall, the superficial fascia has 2 parts to it, an outer part and an inner part. The outer part contains fat, so it's a variable thickness depending upon how much fat you have, and that's called the fatty layer. It's also called Camper's fascia. Deep to that, there's a very thin layer of fascia without any fat. It's called a fibrous layer. On everybody, it's very thin because there is no fat in it. And that's called the fibrous layer or scarpous fascia. Then the next three layers we'll call layer 3, 4, and 5, each has a muscle associated with it. And those three layers are called the external oblique layer, the internal oblique layer, and the transversus abdominis layer. Now this is where I want to expand on what's in the book, because this is really important to understand if you're going to understand the inguinal region. Each one of these three layers, each one of these three layers, external oblique, internal oblique, and transversus, each has three components to it. The same three components for each layer, but each one has three components. One component of each layer is a muscle. So there's the external oblique muscle, an internal oblique muscle, transversus abdominis muscle. Secondly, realize that every place in the body, every place, whenever you have a muscle, at the end of that muscle, there's always a tendon. And the tendon always has the same name as the muscle. Now, at the end of my biceps muscle, there's a tendon, and I call it the biceps tendon. So it always has the same name. In the abdominal wall, instead of calling it a tendon, we call it an aponeurosis. Fancy name for tendon. Just means it's a wide, flat tendon. So there's an external oblique aponeurosis, there's an internal oblique aponeurosis, there's a transversus abdominis aponeurosis. It's not the same thing as the muscle, but it's in the same layer as the muscle. It shares the name with the muscle. And then thirdly, every place in the body, wherever you have a muscle, that muscle is covered by a layer of deep fascia, and that fascia that covers the muscle always has the same name as the muscle. So the biceps muscle in your arm is surrounded by biceps fascia. The triceps muscle is surrounded by triceps fascia, and so forth. So that means the external oblique muscle is going to be surrounded by external oblique fascia. So that's the third component, fascia. Now the fascia that covers the muscle, any muscle, when you get to the end of the muscle and you reach the tendon, the same fascia that covers the muscle keeps on going and covers the tendon. So this external oblique fascia doesn't just cover the external oblique muscle, it also covers the external oblique aponeurosis. So each of the three layers will have a muscle and an aponeurosis and a fascia that covers the muscle and aponeurosis. And each of those three structures will share the name of the layer. So an external oblique muscle, external oblique aponeurosis, external oblique fascia, and so forth for the other layers. Don't confuse those three things with one another. They're different, and we have to deal with them differently. Okay? Next, layer 6. There's another layer of fascia. It's called the transversalis fascia. What the transversalis fascia is it's just a part of a continuous layer of fascia that lines the inner wall of the abdomen, the inner surface of the abdominal wall, which the general name for it is endo-abdominal fascia. And the endo-abdominal fascia that's on the anterior wall is called transversalis fascia. If it's on the posterior wall, it's got other names. If it's on the roof, it's called diaphragmatic fascia. It's simply named according to what it's most closely in contact with. But the whole thing is endo-abdominal fascia. So on the anterior wall, since it's just under the transversus layer, we call it the transversalis fascia. But don't confuse transversalis fascia with transversus abdominis fascia. Those are two different things. This is the deep fascia of this muscle. This is the endo-abdominal fascia. That's deep to that. I'm going to skip layer 7 for a minute and go to layer 8, the innermost layer of the wall, which is parietal peritoneum. Once you get inside the parietal peritoneum, you're not in the wall anymore, you're in the peritoneal cavity. So this is the innermost layer of the wall. That layer I skipped, layer 7, because it's the layer just outside of the parietal peritoneum. It's called the extraperitoneal layer, the extraperitoneal layer. Now, on the anterior abdominal wall, the extraperitoneal layer is remarkably uninteresting. There's not much in it. There's a little bit of fat, a little bit of connective tissue. There's some blood vessels, small blood vessels that run through it, but nothing much of importance. But if you're in that extraperitoneal layer, on the anterior wall. Stay in that layer and just work your way around to get to the posterior abdominal wall, still on that same extraperitoneal layer. You'll see that the layer gets very thick, has a lot of fat and connective tissue, and embedded in that fat and connective tissue is a whole bunch of organs in the extraperitoneal layer. Organs such as the kidneys and the adrenals and the ureters and the aorta and the vena cava. All of those structures are in the extraperitoneal layer. Now, if the kidneys are in the extraperitoneal layer, I want to remind you that yesterday, at the beginning of our session yesterday, we pointed out how the kidneys and the gonads develop side by side in that urogenital ridge. So that would suggest to me that if the kidneys are in the extraperitoneal layer, that's where the gonad must be too. That's where, at least where it developed. So for the male, what we're saying is that the testis develops in that layer, in the extraperitoneal layer. Let's restrict that discussion to the male for now, and then we'll do the female afterwards. So that's where the testis starts. We know that in the adult, or at least postnatally, the testis doesn't stay in the posterior abdominal wall near the kidney, right? It ends up in the scrotum. So the question is, where does scrotum fit into this picture? And so the scrotum is really just an evagination of layers 1 and 2. It's an outpocketing of skin and superficial fascia. That's what the scrotum is. That evagination doesn't have any fat in it, so the fatty layer is missing in the scrotum. There is no campus fascia. And the fibrous layer is present, but it has a different name. Instead of calling it scarpus fascia, it's called dartos fascia. But it's the same fascia, different name. So what we're saying is that layers 1 and 2 become the scrotum. So if the testis is in the scrotum, that means the testis must be just under layer 2, in the plane between layer 2 and 3. So the question is, how did the testis get from here, where it develops, to here, where it lives in the adult? And the story of how it gets from here to there is called the descent of the testis. And the pathway that will be described by that descent is going to be called the inguinal canal. Okay? So the pathway to get from here to there is going to be the inguinal canal. Now, looking at this chart, I would say that in order for the testis to get from here to there, it has to somehow get past 1, 2, 3, 4 layers of structures that are in the way. Okay, and we're going to have to figure out how the testis could do that. But first, I'll tell you that the task is made a little bit easier because in the inguinal region, in the lower abdominal wall, layers 4 and 5, the internal oblique and transversus layers, are fused together. So we can consider those two as if they were one layer. So now instead of having to worry about 4 things in the way, we only have 3 things in the way. The transversalis fascia, then the combined internal oblique and transversus layer, and then finally the external layer. Okay? And if we can figure out how to get past each of those, we'll end up where we want to be. So the testis is here, wants to move in that direction. The first thing it encounters is the transversalis fascia. So what's it going to do about the transversalis fascia? Well, there are only really 2 choices. If it wants to get past the transversalis fascia, it can do one of 2 things. Either cut a hole in the fascia and go through the hole, but there's really no way for it to cut a hole in the fascia, so it can't do that. The only other choice it has is to push the fascia in front of it, evaginate the fascia, and get covered by that evagination. And that's what happens. The transversalis fascia is evaginated and ends up covering the testis as the testis proceeds. That evagination of transversalis fascia is going to be called the internal spermatic fascia. And the point at which it evaginates the fascia to become internal spermatic fascia is going to be called the deep inguinal ring. And so at the deep inguinal ring, transversalis fascia will get evaginated. It'll cover the testis, and not just the testis, but as the testis is taking this journey, is migrating, it's dragging with it all the things that it needs to live, like an artery and a vein and lymphatics and nerve and a duct, and collectively those things are going to be called the spermatocord. So this fascia that gets evaginated doesn't just cover the testis, it covers the testis and the spermatocord. And so based upon what we just said, we've gotten the testis from here to here, from one side of number 6 to the other side of number 6, but we didn't do it by going through layer 6, we did it by just evaginating layer 6 and taking it with us. So let's take a look at the picture that describes what I'm just saying in words on page 235. So first let's see how this picture relates to the chart. So starting from the inside, we have layer 8, which is the parietal peritoneum. Right? Just outside of that is layer 7, the extraperitoneal layer. That's where the testis starts. Outside of that is the transversalis fascia. Outside of that is the transversus abdominis fascia, and as we said, there's a muscle, there's an aponeurosis, and then covering the muscle and aponeurosis on both sides is fascia. Outside of that, we have the internal oblique layer, number 4. Again, we have a muscle, we have aponeurosis, fascia covering it on both sides. Outside of that, we have the external oblique layer. Now, in this diagram, we only see the aponeurosis and the fascia covering the aponeurosis because the muscle ended much more laterally. Way out here, there'd still be muscle, but here there's just aponeurosis and fascia. And then layers 1 and 2 are not shown on this diagram. The skin and superficial fascia have been removed. So we said that the testis started here, starts heading in this direction. It evaginates the transversalis fascia. The point where it evaginates it is called the deep inguinal ring. And then the fascia that is evaginated at the deep inguinal ring that gets dragged out, covering the testis and spermatocord, is what we're going to call the internal spermatic fascia. So we're 1/3 of the way there. Okay, we've taken care of layer 6. Now we said that layers 4 and 5 are fused, and we can see them fused over here. They're actually even more fused than this picture shows. And so we'll deal with it as if it's one layer. We'll use layer 4 to describe both layers at the same time. So there's the internal oblique muscle. Okay. It's covered by fascia on both sides. There's the aponeurosis. Now, if we look at the orientation of those muscle fibers, we'll see that they run obliquely, upward and medially. That's why it's called oblique. But as we get toward the medial end of that muscle, the muscle's going to end right about there. Just before we get to the end of that muscle, the direction of the muscle fiber starts to change, and instead of running upward and medially, they start to arch around like that. When a structure forms an arch in anatomy like that, the name we give it is falx. So since this is a falx, you remember in the cranial cavity, in the dura, you had a falx cerebri and a falx cerebelli. So this is an arch in the inguinal region, so we call it the falx inguinalis. The reason these muscle fibers are doing that, the reason they change their direction to form this arch, is that leaves a gap under the arch where there's no muscle. And that's handy because we want to have a place where the testis can come, where there won't be any muscle in the way. So the muscles form an arch so the testis can slip under the arching fibers. And that's what's going to happen. But even though there is no muscle here, the fascia that's covering the muscle is there. So that gap under the falx inguinalis is covered over by the internal oblique fascia. So as the testis and spermatocord come down and they want to pass under those arching fibers, they find that there's fascia in the way. So what do you think it does to the fascia? It evaginates it. And it'll end up covered by a second layer of fascia. So let's see what we're saying. Saying that evaginated internal spermatic fascia keeps coming down, then we pass under these arching fibers, and it evaginates another layer of fascia, that internal oblique fascia. But when that internal oblique fascia gets evaginated, some of those internal oblique muscle fibers, right on the very edge of the falx, some of those muscle fibers get caught up with that fascia, and they evaginate as well. So what gets evaginated is not just fascia, but skeletal muscle and fascia. Those evaginated muscle fibers are given the name cremaster muscle, and we always name fascia the same as the muscle, so that's going to be called the cremaster muscle and fascia. And that now is a second layer covering the testis and spermatocord. The innermost layer was this internal spermatic fascia, which was the transversalis fascia. And then once we pass under the forks inguinalis, we have a second layer, which we call the cremaster muscle and cremaster fascia, which is really just the internal oblique muscle and internal oblique fascia. So now we're 2/3 of the way there. We just have to deal with the external oblique layer, which is at this point external oblique aponeurosis. So we need to get through the aponeurosis, and it turns out that there is a hole in the aponeurosis. Very convenient. There's a hole in the aponeurosis. That hole is called the superficial inguinal ring. So that provides a place where the testis can get through that layer. But even though there's a hole in the aponeurosis, the fascia that covers that aponeurosis doesn't have a hole in it. So the external oblique fascia is covering that superficial inguinal ring. So if the testis wants to come through the superficial inguinal ring, it has to evaginate the external oblique fascia, and it does that. And that evaginated fascia is now given the name external spermatic fascia. So once the testis with its spermatocord has come through the superficial ring, it's now covered by 3 layers of fascia. The external spermatic fascia, which it picked up from the external oblique fascia at the level of the superficial ring. Deep to that, there's the cremaster muscle and fascia, which it picked up as it passed under the forks inguinalis. And inside of that, there's the internal spermatic fascia, which it picked up at the deep inguinal ring. Once it comes out through the superficial inguinal ring, meaning it's come out past layer 3, that means it's now in the plane between layers 2 and 3. And of course, remember, layers 1 and 2 is what evaginates to become the scrotum, so that means this can just slide down into the scrotum. So that pathway that we just described that starts at the deep inguinal ring and ends at the superficial inguinal ring, that pathway is the inguinal canal. Okay? All right, so we've taken care of the descent of the testis. We've created the pathway that we call the inguinal canal, and that sets us up to discuss inguinal hernias, which is what we will do as soon as we start tomorrow, 6 p.m. Eastern Time. Again, last reminder, download and print out the handout. That's in the file share pod. And hope you all enjoy the rest of your evening. And I will see you tomorrow evening, 6 o'clock Eastern Time. Thanks. Good night.